Welcome, everybody. I hope that you had a good start into the day, also with the pillar sessions that had already taken place. I want to thank you all for being here to our panel discussion and to our symposium. We're really, really happy to be hosting such esteemed panelists today. We're going to, in this session, in the coming 3 hours, be focusing on various aspects of the ongoing COVID-19 pandemic as it has affected us all. It, as we all know, has shown difficulties in the healthcare system, also with vaccination discussions starting nationally on the European level as well as globally, and different various ethical aspects coming up as well. We will firstly start with a keynote address by Dr. Kluge, the WHO Regional Director for Europe. Afterwards, we will go into a panel discussion on the experiences of doctors in Europe, followed by ethical aspects, and last but not least, the vaccinations and rolling review process of the European Medicines Agency. Dr. Kluge, thank you so much for joining us today, and I will hand over to you.
Thank you very much. Do you hear me well?
Yes.
And hello, everyone, representatives and members of the European Medical Students Association, colleagues, friends. I'm speaking to you, as you probably see, from the Greek flag, from Athens, where 2 days ago, we opened with the Ministry of Health a new WHO sub-regional office on quality of care, an often neglected aspect of universal health coverage. Where are we today? We are fast approaching 150 million reported COVID-19 cases at a global level, 50 million at a regional level. And you know, the WHO European region, for me, encompasses 53 member states. So it's the pan-European region. And this pan-European region is the second worst affected by COVID-19 of all the world's 6 regions. More than 1 in 3 deaths caused by COVID-19 occurred in the pan-European region. And less than a year and a half ago, just to remind, the virus SARS-CoV-2 was unknown to us. So I always say, yes, there have been defeats, but also not to forget some groundbreaking scientific progress, such as the development of the vaccine. I mean, usually it takes about 5 to 10 years to develop a vaccine. Now we have a group of them already after 1 year and a half, with approximately 15% of the population in our pan-European region having had a first dose of. Vaccinating health workers is the key part of our vaccination strategy. We have always been stressing this. And the fact that in 28 countries in this region, nearly 80% of the health professionals had their first shot allows the health systems to better sustain the enormous pressure they are under. So it comes without saying that some of the greatest achievements in the fight against the SARS-CoV-2 virus have been carried out by the health workers on the front line of this fight. I always say they are the heroes of the pandemic. And that's why I always take pride to meet the healthcare workers in every country that I'm visiting. Also here in Greece, we went with our team and WHO representative to speak to the healthcare workers in one of the camps of the asylum seekers, also in the Prometheus mega vaccination center, and to listen to the stories of the healthcare worker and the people. Nurses, midwives, physicians, pharmacists, paramedics have for 15 months played a critical role in the testing, contact tracing, diagnosing, treating, accompanying COVID-19 patients, vaccinating patients, while also trying to provide other essential health services. And this is a priority now to get back on track. Even if we're facing third wave in several countries, we have to pick up with the non-communicable diseases, other communicable diseases, routine immunization, and particularly take care of the mental health. In the beginning of the outbreak, at times, the health workers worked without adequate protection against the virus, putting their lives and the lives of their loved ones really on the line. Young professionals like you played a critical role in the response, but you also have been exposed to high levels of stress, increasing the likelihood of abandoning the profession and burnout. And that is why some of the challenges ahead of us include the need to improve recruitment and retraining while better retaining the health workers. We know that the impact of the pandemic will reverberate for the years to come. Health emergencies like the one we are living through have a past of bringing about societal, economic, and cultural changes, and this pandemic is no exception. Some of the consequences of the virus are negative, others are positive. Some maybe even timely. And remember that every cloud has a silver lining. The lessons learned are countless, and many of them are painful. A number of them. The pandemic has put health at the top of all agendas. Because of the virus, health is no longer peripheral or a byproduct. And I see this in my country visits. Last week, I was in Romania, had a long tete-a-tete with the president of the country. Yesterday, we were with the prime minister in Greece. The heads of state, the minister of finance, realize everything starts with health. No health, no economy, no social cohesion, a lot of social unrest now, right? No health, no security, and no economic development. Another one, COVID-19 has placed the health workers at the core of a well-performing and resilient health system. At the same time, exposed the risks of staffing and skills shortages. We see this also in WHO, all hands on deck. The pandemic also underlined the importance of valuing, protecting, and caring for our health workforce. Same time, I call it back to the basics. The virus has stressed once again the urgent need for universal health coverage based on a strong primary healthcare with the essential public health functions integrated. For example, surveillance. This is a dreamed opportunity to put public health back at the political agenda. I always say, if we do a good job with public health, no one notices it because we protect the people. It's when something goes wrong that public health comes to the attention of the people and the politicians. Last but not least, the pandemic reminded all of us the heroic work of the health workers. Yes, it unveiled the challenges and the risks, including healthcare associated infections, why it is so important we opened the office here in Athens on quality of care, but it also exposed to domestic violence, stigma, psychological, emotional disturbances, illness, and unfortunately, a lot of deaths. So what does all of this mean for you as health workers in the long run? It does imply certainly a higher workload. And we are asking health workers to respond to COVID-19 while maintaining essential services. The new normal also implies a higher exposure to COVID-19 infection. In fact, health workers are likely to account for 8% of the cases the world over. Among some of these grave and negative consequences on the health workers is increased mental stress, absenteeism, and the appearance of different psychological conditions, such as anxiety and depression. But luckily, there are plenty of solutions and measures to adapt. I always try to look at the bright side. Several countries, and I have noticed it myself, have successfully increased surge capacity by repurposing and redeploying the existing health workforce and by mobilizing and recruiting additional staff, including students and volunteers. Last week, I told you I was in Romania, and there was a law passed very quickly for medical students of the last 2 years to function as nurses in the hospitals, performing some essential nursing duties with a financial incentive. And it tremendously increased already the workforce. Workers have taken on new responsibilities also, and many have rapidly adapted innovative technologies to deliver care, sometimes remotely, digital. All of this is quite likely to continue and should continue. The COVID-19 further has accelerated new ways of working and the use of new technology. The investment in the digital health is already supporting overworked health workers and providing safer, more flexible ways of working, including for women who form the majority of the health workforce. In this region, the pan-European region, 84% of nurses and 53% of physicians are women, but not enough yet in leadership positions. What is clear is that we need to collectively invest appropriately and adequately in the health workforce for it to be sufficient, capable, and motivated. I believe we will experience effective multi-professional collaboration, improving the quality of your education and training, increasing the focus on public health, and promoting ethical, sustainable international recruitment of people in your ranks. We will also see a focus on redeploying and developing new skills and competencies among health workers. Some final thoughts beyond your field of work now. WHO, myself, also gets asked often about the new normal. But many people seem less interested in the measures that will get us there, such as public health and social measures, not to mention getting vaccinated. That in itself is a tremendous challenge. The global solidarity, multilateralism should not be treated as empty words. Solidarity, as a matter of fact, is the fastest, most effective way to defeat the pandemic and get our lives and economies back to some sort of normal. But solidarity coupled with pragmatism. A new normal can be many things. Some decades ago, living with HIV was not normal, whereas today, doing precisely that is normalcy to millions of people. We have not eradicated HIV, but we have learned to live with it. And the same may apply in the context of COVID-19. The fact is, the disease is likely to be with us for a long time and eventually to become endemic. So vaccines alone will not return the world to a pre-COVID-19 world. We are looking at 2022 before enough people have immunity through vaccination to seek community protection from COVID-19. There are no shortcuts. There will be no return to the old normal for the foreseeable future, and neither should there be. Because remember, the old normal is what got us here in the first place. At the very roots of COVID-19 is the lack of understanding of the intrinsic link between human health, animal health, and environmental health. That's why I signed an agreement with the region directors of FAO, the Food and Agriculture Organization, and IEO, the World Organization of Animal Health, to work together as a tripartite, because we know that the next threat will most likely be again zoonotic, jumping from the animals to the human beings. When I get asked what the future holds, my response is that it's very much up to ourselves and how we make use of the lessons learned for which we have paid so dearly. But as a realistic optimist, I see innovation driven by the need, accelerated societal changes and progress. Challenges for sure, but also a global community that has finally understood equity, that no one is safe until everyone is safe. Thank you.
Thank you so much. We already have a few questions coming in through the chat. I would just ask one question that we have prepared beforehand. You mentioned that we have learned a lot of lessons from the pandemic, and that is 100% true. We see that on the national level, on the local level, everywhere. There's a behavior that has been changed based on lessons that we have learned. In your opinion, what do you think that still needs to change for us in Europe to be able to tackle the pandemic a little bit better?
I see a number of points here. So to tackle it better, currently, we are facing in the countries pandemic frustration. I used to call it pandemic fatigue, but in several countries it became a frustration. That's what ministers and heads of state were telling me, sometimes becoming violent. So we need to listen to the communities. Dr. Tedros, the WHO Director General, was asked last year by the World Health Assembly, which is WHO's global governing body board with 194 ministers, to establish the IPPR, independent panel to review the preparedness and response. It's co-chaired by former Prime Minister Helen Clark and former President of Liberia, Sirleaf Johnson. And the President of Liberia was telling WHO and policymakers need to listen again to the frontline workers, to the patients. And that's why always, immediately when I meet the head of state, I want to go to the primary healthcare center. That's why I went to the asylum seeker center as well. I think we need to find better ways, engage with civil society, with the communities, not to point the finger at them, but try to get them on board. And that's why I created the Behavioral Insight unit in WHO with anthropologists, psychologists, the human scientists, because I learned this from my time I was working in Africa, that doctors and nurses are essential, but as essential are the human sciences to better understand the perception of the people and then to design adapted strategies, not one size fits all, because without the communities, without NGO, civil society, it will be impossible to leave no one behind.
Yes, that is very, very true. We have two questions in the chat. I don't know, because I know that you are pressed for time. If we can go through them, maybe the first one we can try, and then if there,
sure, no hurry.
Okay,
no hurry.
Okay. The first one is, what could a country like Germany, for example, do differently to strengthen the pandemic response in the European region and globally? And which European country is very successful, in your opinion, using low resources in the European region?
Right. So the first one is, I see it here, what a country like Germany do differently to strengthen the pandemic response, okay, in the region. Well, first and foremost, I must say that Germany has been doing a lot. Germany had last year the presidency of the European Union and passed a number of council conclusions in the EU to strengthen the EU's role and Germany's role in global governance, and to have a stronger WHO. Is also an important financier of WHO, but I always look from a European perspective, whether it is Germany or other countries. One of the other things, Alexandra, right, I could have told on your first question, is coherence. If you want to get out of this pandemic, so policy coherence. We see it, for example, now with vaccines, with AstraZeneca. And one country, this age group, one country, then a country, if not going to use it like Denmark. And very practical, this morning, with my colleagues here of the WHO country office, I was meeting His Beatitude, the Archbishop, because soon in Greece, there will be the Orthodox Easter, and Greece is doing very well, I mean, really is doing very, very well, but there is a third wave, like in many countries. So what we're discussing is how to, if society is opening, how to do it safe and gradually. And if different countries are doing it differently, you know, we're not going to get there. There has to be some coherence, right, on gradually and safe opening. Because the time that a country can shut down, open, people don't take it anymore. I mean, people are too tired and frustrated. So there has to be a coherence. And that applies to other fields as well. For example, when now people speak more and more about the green digital certificates, right, for the vaccines. I mean, if countries are going to use it as a passport, we don't stand behind it. We support a smart certificate, but not that it will be a condition to travel or not, because that will create quite some iniquities. And it even may prioritize people who travel for a vaccination instead of healthcare workers in less resource, in more resource poor countries. Which European country is very successful using low? You know, this is a question always people, and especially journalists, are asking me, and which country is the best and which is the worst? You know, we are not there to, we are there to support, I always say, WHO is not the World Health Inspectorate, right? I think we have to do a better job at explaining what is WHO. And even my own daughter say, and why don't go to the minister and boss him around, you know, or this, because he's not wearing the mask. But this is not how we are. You should see WHO as you could compare it, employee governed organization, right? So the shareholders are the member states. It's not Hans Kluge who is, right, let's say, I'm the secretary, the support, but the ownership is with the member states, and we are there in support. And frankly speaking, I think it's Philippa who asked the question. Dear Philippa, I have seen in all 50 countries political, operational, technical support being mobilized. Every country did amazing things, and every country made mistakes, including WHO. And what we have to do is not now to go after each other, but to be open-minded and to learn and not to wait. WHO used to do a after-action review. When the pandemic is finished, we learn the lessons. I want to be ahead because we're still in there. We need to intra-action review, right? But low resources have been, it comes back to innovation. People speak about innovation. You know what for me is definition of innovation? Innovation for me is implementing what we know is working. It's not something very fancy. If we will implement what we know is working, I think we will be already very innovative. A very concrete example is primary healthcare and public health. A strong primary healthcare system with community surveillance is key, because we saw in countries where patient zero was running around and it took 3 weeks before the patient was being picked up, those countries were running behind the time and the facts. Thank you.
Thank you so much. I know that you have to get going probably, so unfortunately we won't be able to answer the other questions that are coming in, but thank you so much for taking the time to speak to us. Maybe one last very short question from me would be, what would you tell the medical students that are listening in? What would you tell them as advice, or also what would you tell them to do in the coming months? How could we support?
Yes, I have a very clear message here to the medical students. You have chosen such an important profession. Your role is so important and it is valued, and we have to keep it very high. But please always, whatever you will choose to be, balance between curative care and prevention. Also in WHO, before me, there has been tension. What's more important, the public health and the prevention and the promotion, or the curative care? Every one of us is either a patient or a potential patient. So we need very good curative care. We need good hospitals and technology. But in order, definition of public health, right, to prolong our life with good quality, not in disease, but healthy lives, we need a culture of health. We need to tackle the lifestyle challenges, obesity, smoking. I was congratulating Prime Minister Mitsotakis yesterday here. I mean, for the first time in history, there was a law on banning smoking in public places. I mean, against the pressure of the industry. It's not a small thing. It's a huge thing. We need this. So it doesn't matter. And then the other one is respect very much your nurses and midwives. Nurses and midwives are the biggest workforce in the region. And because of conservative mentality of doctors, which I'm one of them, I mean, hopefully not a conservative one, but a medical doctor, and I'm proud of this, right? Several countries, and often the richer countries in the EU, are very old-fashioned, you know, Herr Oberarzt, and then, we cannot do it all. Increase the task profile of the nurses and shift some of the work of the nurses to the community volunteers and the social workers, so that all of us can do what we can do best. But I'm very proud of you all, Alexander. That's why even in between two meetings here, I made a time, and I will always make the time for you, because I think it's very important also for me, these questions you're asking me. No, I will think further about this. And I would like to express my appreciation to all the next speakers. I had in front of me here, and Ray and Alessandro and Ellen and Dr. Kloiber and Marilee, and Manuela. So I apologize that I will not be there to listen to you, but if you can send me a summary, I'll be very happy to read. Thank you so much, and stay healthy.
Thank you so much for making the time. Thank you, and good luck with the next events coming. Bye-bye.
Thank you. Goodbye.
Okay, before we move on to the next, to the panel, we have one question for the audience. In the meantime, I will get the presentation up and running, because Dr. Kluge also mentioned the COVID fatigue. So we have the question, if you are personally also experiencing the fatigue in the with the ongoing restrictions, let us know what you think. We're getting a lot of yeses. That was to be expected, but I will open up the presentation in the meantime. And we will be moving on with Dr. Raymond Wally, the CPME first Vice President. As you may know, the CPME is one of our close collaborators, and we're very, very happy that you, Dr. Wally, could be here today with us. In terms of, your other responsibilities, you're also a general practitioner currently in Dublin, Ireland, as well as an undergraduate clinical tutor for the general practice component of the training at the University College in Dublin, as well as being a member of the National COVID-19 General Practitioner Advisory Team and a member of the Medical Legal Advisory Panel of Medisec Ireland. I will share my screen now. Thank you so much for being here. And in the meantime, the answers to our poll will just keep trickling in a little bit, and feel free to start.
Good morning from Dublin, and I'm thankful to say that it's a sunny Dublin. Also within that, I'm the proud father of a first-year medical student in Dublin, so it gives me great heart to be able to present and talk to you on a very appropriate heading, the new normal. So today I'm representing CPME, and I'm the first Vice President of CPME. CPME is an organization representing national medical associations across Europe. We have a full-time office in Brussels. We are ably led by Annabelle Seebohm, our Secretary General, and our President, Franz Ulrich Montgomery. We are definitely a very European organization with vice presidents from all the different European countries. We are committed to contributing the medical profession's point of view to EU institutions and European policy making through proactive cooperation on a wide range of health and healthcare related issues. If one is to go on our website, you will see the different documents that we have done in the last few years. Most recently, telemedicine. I would be responsible for a digital health responsibility. So we're very timely in what we do. We're very proactive in what we do. We promote the highest level of medical training and practice, but also provision of evidence-based, ethical, and equitable healthcare services. Next slide, please. To support countries in the pandemic, we have provided a lot of knowledgeable exchange between our 38 countries participating. We have status reports from the National Medical Associations, which capture doctors' experiences initially from March to July 2020. Again, we started it again in September 2020 to reflect the second wave. We have been providing a standardized questionnaire which looks at information in regard to availability of human and technical resources, testing, treatment protocols, impact on doctors' health and professional practice. A summary was published in November together with other health stakeholder data. On the basis of national medical organizations' experiences, the main lessons learned were processed into policy recommendations for pandemic preparedness at EU level. We've shared these with the EU Commission and the EU health organizations and the European Union health representatives. We produce a European Union health package. The European Union is producing a European health package with 3 draft laws which aim to strengthen EU Medicines Agency and the European Centre for Health, Disease and Prevention. We have reinforced our opinions in regard to this by seeking collaboration from our national medical associations and providing a briefing in regard to our opinions like this. Recently, we have created a new working group to discuss questions of medical ethics arising from COVID-19 pandemic, including national approaches to triage, policies on off-label use of medicines in treating COVID-19 patients, and in risk assessment processes. The working group will take up its activity shortly. European medical organizations are also always welcome to join this. Next slide, please. From March to July 2020, CPME coordinated and published an extensive collection of status reports for NMAs. It covers headings of supplies, workforce, and the second wave, third wave experience. The outbreak of COVID-19 pandemic caused severe shortage of medicines, medical devices, including PPE in Europe. I remember, and many of you will do, remembering seeing some countries where medical staff were using black bags. In our country, our ordering of PPE went from 37 million to 1 billion, with 250 Airbus aircraft flying from Beijing to Dublin for the first time. There was never a previous route. I'm sure that was equally copied in many other countries. The CPME survey reveals most of the EU member states were caught unprepared to respond to the health crisis, unable to secure early access to essential therapeutics and technology for treating COVID-19 patients. By being members of a brotherhood, sisterhood, European Union, it did help in accessing many of these different issues. PPE was scarce in almost all countries, including Ireland, at the beginning of the pandemic, and while supply stabilized in most countries, some still report shortages or insufficient quality. We need to continue asking for our countries to provide our healthcare personnel with adequate PPE. That's the least we need to expect. Medicine shortages were in some cases mitigated by repurposing of veteran medical products, and that was part of the dynamic, flexible changes that many countries did. In regard to workforce, the majority of NMAs reported major changes in organising the work in hospitals. In Ireland, certainly we had a very hospital-centric approach. We recognised the strength of general practice primary care, and we repurposed much of our attention to the fact that 80-85% of COVID-19 healthcare was going to be in the community, with only 15 to 5% ending up in hospital and in intensive care. We noticed that our national medical associations cited physical and mental exhaustion. Others reported instances of harassment or intimidation of doctors. Very, very sad. Several NMAs, such as Greece and Latvia, have created helplines for their members to provide psychosocial and professional advice and support. Some countries have paid monetary acknowledgements to healthcare personnel. Also, some countries recognize COVID-19 infections and deaths as an occupational incident. However, it is unclear whether this is resolved with a view to long-lasting damages and invalidity. That needs to be clarified, and CPME certainly will be looking for clarification on that. Next slide, please. Actually, if you return to the last slide, please. Since September 2020, information collected by CPME, as I stated before, has resumed and has been adapted for the second and third wave. Many countries are facing a significant backlog of treatments, including in my own country, to intentionally postpone elective procedures. Late diagnosis of conditions such as heart attacks and strokes, from reduced availability of services or patients hesitate to visit a doctor, is unfortunately happening on a regular basis. Some countries estimate it will require several years to tackle this and highlight systemic health workforce shortages. Unfortunately, what COVID-19 has done, it has found out the deficiencies of our different healthcare systems. Healthcare professions are prioritized for vaccination in all countries. However, some differentiate between frontline professions who are especially close to COVID-19 patients or risk groups and others. Next slide, please. Ireland suffered a third wave in and around the Christmas period. Initially, it was thought to be due to the fact that our shops and social society and our restaurants opened up at a certain pace. It was thought it was that which unfortunately led greatly to this. That was probably a contributing factor, but laterally it appears it's the B117 UK variant, which is more infectious. In January, our intensive care units were on a precipice over a 1 to 2 week period that they would collapse. Thankfully, we came out of that and we're now on the downslope. Next slide, please. This is a slide showing the hospitalizations and ICU admissions over the December-January period. As you can see, the peak in and around early January. Next slide, please. I list 3 slides as the context of where Ireland stands. We have of these countries, the lowest number of medical personnel. And next slide, please. The lowest number, one of the lowest numbers of hospital capacity in infrastructure beds, would regularly, prior to the COVID-19 epidemic, our hospitals at 102 and 103% capacity. Next slide, please. And as you can see, we had the lowest number of ICU beds. Thankfully, some of this is being augmented, but as all we well know, it's easy to provide infrastructure. To provide staffing for each bed requires 6 intensive care nurses and intensive care physicians, all of which take many years to plan and train. Next slide, please. A recent study done in the period 21st of December to the 18th of January indicates the stress levels in regard to our staff. This has been presented today for the first time at our own AGM, which happens in about a half an hour's time. You can see the significant burnout stats in regard to that. Burnout is a state of emotional, physical, and mental exhaustion where you have excess workload, prolonged stress, you are overwhelmed, emotionally drained, and unable to meet the constant demands. It is concerning that such a high percentage of medical personnel, and probably our nursing and midwifery personnel and other healthcare personnel, were prone to this. This was precipitated by, during the Christmas, December, January pandemic, we had a doubling on a weekly basis in regard to our admissions to hospital. The survey was carried out between the 21st of December and the 18th of January. There were 1,100 IMO members who contributed. We have a membership of approximately 7,500. So that's a response rate of around 15%, 12 to 15%. The overall self-reported health was good. The survey revealed high level of stress and burnout among doctors. As shown there, 79% of those who responded to the survey reported that the pandemic had a negative impact on their mental health. Next slide, please. This is a more detailed breakdown. Prior to the pandemic, pre-existing staffing shortages made worse by COVID illness and requirements to self-isolate if one became sick. 1/5 of consultant posts were unfilled or filled on a temporary basis prior to the pandemic. Prior to the pandemic, unfortunately, we had the financial crisis, which greatly affected Ireland. And as a result of that, we had a great reduction centrally in regard to the salary. And increasingly, we have had vacancies, people resigning for posts in the financial crisis or posts being unfilled. So unfortunately, the pandemic found the deficiencies out in our healthcare system. The capacity in the system to cope with both COVID and non-COVID patients and a growing backlog of waiting patients is continuing to occur. Waiting lists for hospital appointments and elective care have grown by more than 10% in the last year. During the third wave, GPs reported that 52% of non-COVID consultations took place by telephone or video, whilst 44% of hospital specialists reported that clinics were taking place via telephone video consultations. However, satisfaction with telemedicine was mixed amongst GPs and hospital specialists. As a full-time general practitioner in Dublin, it has brought to the fore the importance of face-to-face consultation. Unfortunately, when we're assessing our elderly patients, you do not necessarily know that they're in pain because they don't necessarily complain about it. You do not necessarily notice that they're actually grimacing when they're walking into your consultation, all of which isn't necessarily visible on televideo. And out of that, partly our telemedicine position paper has come, recognizing that telemedicine is a poor substitute to face-to-face consultation, which we in CPME have advocated now as the gold standard. The survey also revealed the significant impact that the pandemic has on doctor training. Junior doctors reported being unable to attend educational events off-site or their training being moved online, whilst for some training was cancelled or exams were delayed. Many reported that the quality training had also suffered. At the time, there were few concerns in relation to COVID vaccinations. However, recently, there are growing concerns among doctors in relation to vaccine hesitancy among patients. Next slide, please. This is a slide put together by CPME, indicating different concerns throughout Europe of different issues. We have reported these concerns to the EU, and these are reported across the EU. Pandemics, as we well know, knows no borders. And through CPME and other European medical associations, we've been able to share the experience and build a united front. It is very important that we have a united voice. CPME surveys and special meetings on country response to COVID-19 offer the opportunities for national medical associations to share their concerns. CPME has represented European doctors with firm policies on pandemic preparedness, medicine shortages, telemedicine, and vaccinations. We've given valuable input into European Commission proposals for a regulation on cross-border threats to health, as well as proposals to strengthen the roles of both European Medicines Agency and the European Centre for Disease Prevention. Thank you.
Thank you so much. I saw that somebody had raised his hand. If you have a question, I would ask you to please put it into the Q&A box at the bottom of the screen. There's something that says Q&A, so if you could put that in there, that would be great. Because I know that you also have to go to your national associations meeting. We will move on to two of the panel questions that I will be asking the other participants later on as well. So the first question we have, in the meantime, please, as I said, put in any kind of questions you have into the Q&A section. The first question we have is, we have recently noted the 1-year anniversary since the first case of COVID-19 was registered in the European Union. Linking a little bit to what Dr. Kluge was saying as well, what have we learned for possible future pandemics? Because I know that the CPME has also been looking at that, as you were saying specifically.
Yes, I think you'll find there will be a sameness in the responses, I think, of the majority of people. I will quote Dr. Mike Ryan of the Health Organization. Prepare, prepare, prepare. And that still is the adage that we need to be using. It has raised the importance of appropriately, properly resourced public health infrastructure. We're talking about consultant trained, specialist trained, recognition of these specialists, recognition of their special training, and appropriate resourcing of those people. So in Ireland, for example, we are still using spreadsheets in regard to managing contact tracing in an environment where you've got such computerization that is unacceptable. I'm sure that is occurring in some other countries as well. It is 1978 since we emphasized the Alma Ata Declaration of the importance by the World Health Organization of community care, general practice, primary care. Yet many countries are not resourcing that to the extent that it should do. It is very important that we have appropriate staffing, appropriate infrastructure, appropriate training. It has also raised the importance of good medical leadership, and we're out there doing the debates with the non-medical people who suddenly have become experts on everything. So for example, in Ireland, I would be part of a group of people who do medical communication, especially in vaccines and other areas. And it's very important that that is kept to the forefront, because very easily things can get ahead of us in regard to negativity towards vaccination with inappropriate, inaccurate representation on issues. And it needs appropriately trained in regard to healthcare, in regard to communication, how we deal with that. CPME has certainly led on that as well in regard to vaccination. We also have the importance of putting forward the importance of vaccination. We have had various platforms, digital platforms, which to date have been allowed to platform negativity towards that. So we need the European Union to ensure leadership is that is managed, because many of these are inaccurate and they shouldn't be given the platform. Laterally, we're seeing the importance of our medical laboratories. certainly within the UK, there is a great focus on genome sequencing. In Ireland, we're now doing genome sequencing to 25% of all cases. And I'm noticing in the US, they're only doing up to 3%. It is very important that we have the appropriate laboratory, scientists, and appropriate resource to ensure that we all work as an integrated care system. Within all of that, and certainly from the experience of Ireland, we need adequate bed provision. We need adequate ICU provision. And we need to recognize you need capacity. Now, nobody's going to meet the tsunami capacity of when you have pandemics growing, but we need capacity built in, probably to 75 to 80%, I think the national target is. But many countries do not have that capacity. Now, none of that is on any specific priority. These are all represented in documents that the CPME have sent to the European Commission, and I'm sure I'm leaving something out.
No, that was already a lot of information, definitely. The second question we have prepared also links to your presentation. You mentioned mental health issues, specifically burnout, on the rise amongst medical professionals. And the question is, with the mental health issues globally being on the rise, the toll of the pandemic is also noticeable in healthcare staff, as you have mentioned. How can the mental health capacity of healthcare professionals be more protected and the effects of the pandemic on mental health mitigated?
I think the first important thing is that we recognize that none of us are Superman, none of us are Superwoman. We're all mortal. The first responsibility for maintaining your health is your own. It also starts with appropriate training, staff resourcing, appropriate infrastructure. People need to have provided adequate leave. They need to take their leave. We need to have appropriate occupational health supports. I was listening to Dr. Klug talking about in one country that medical students were now being used to provide more primary responsibilities. We need to recognize that their training needs still need to be maintained. We need to make sure that their health is maintained. The older medical practitioners have to look after the younger medical practitioners. We also need to make sure that with recognizing that the female women workforce make up such a massive degree of the workforce, that they have unique needs, although some of these issues are not gender-based. I noticed from one of the regulatory authorities some years ago, when there was difficulty in regard to the health and mental health of medical staff, that there was a push for resilience training. That certainly needs to be part of the solutions with this, but the first thing you need to do is ensure the systems are there to support us all to do our job. Because resilience will not take away, will not sort out poor infrastructure, poor staffing, and poor training. And we need all of these systems to be analysed. We need them to be audited with changes by way of the audit process. But getting back to my initial point, first important thing is we need to all look after ourselves by a proper diet, proper exercise, proper sleep, looking after yourselves in regard to the advice we're all giving in regard to not smoking, moderation and alcohol, and recognizing that your family life has a great importance too. We have to look after ourselves first and look after each other.
Definitely, that is a very important message, I think. We got a few questions in the chat or in the Q&A box, to be precise. So the first relates specifically to what you have just said. From Mary McCarthy, does resilience training imply that there is a toxic work environment?
It actually was the GMC who provided the resilience training. I think so, and I was a bit surprised when the GMC provided resilience training. I think, as I said before, I think we need to be willing in a pandemic, coming out of a pandemic, to be willing to look at everything. We need to, the only way we're going to ensure that we maintain our health and that our juniors maintain their health going forward is that the infrastructure is there and the staffing is there. And with that, populations have a responsibility to be educated by states and their own personal responsibility to look after our health. What we are all seeing is, certainly as a frontline general practitioner, I've seen the importance of maintaining cardiac health, respiratory health, maintaining your appropriate body mass index. Unfortunately, there are many more vulnerabilities other than age to this virus, And we all have those responsibilities. But getting back to Mary's question, yes, there are frailties in all our healthcare systems, and we have personal responsibility to maintain resilience, but equally the whole structure has those responsibilities as well.
Another question that we have is, what kind of support do we need to, I think you already answered this, but maybe just to restate it, what kind of support do we need to protect our health workers' health, and who has the most power to change the deficiencies? I feel like you already answered this question, but just to bring it to the point again, maybe.
I think certainly going back to the design of healthcare systems needs to be looked at. We need to have appropriate infrastructure, appropriate training, and we need to, another point within that is that, some of our you guys are medical students. I've got a son who's a medical student. Their training has been interrupted. States need to ensure that that interruption is broken again to make sure that whatever deficiencies that they missed out on, that they occur again. Certainly, it's been difficult. I have a GP trainee with me in Dublin. It's been difficult with the workload to maintain the education needs of my trainee, and we need to be ensuring that any deficiencies that we pick up need to be sorted out. There are a lot of learnings in regard to this. It's very, very important that we audit what we do and we maintain the audit cycle till we learn from this and go forward, because it's going to take a few years to come out of this, and the new norm is going to be that the dangers from zoonotic transmission of infections is with us for life.
Yes. The new normal, that's pretty much what we're focusing on today, isn't it? And that is what we will have to, we will have to deal with in the coming years for sure. I think we'll take one more question. It's a pretty simple one, I guess. Do you think that the vaccination all around the EU will be able to prevent a potential fourth wave coming?
I think vaccination is a significant part of our armory, but we need to keep on emphasizing the basics, and the basics are mask wearing, the basics are proper hygiene in regard to hand washing, keeping your distance from people, proper ventilation, and then we've got vaccination. Now, the likelihood is that we're going to have vaccination, and we're going to have boosters vaccinations. And, what we've got to try to do is get our levels down, our prevalence levels of infection down. We're coming out of this, other countries should be looking at what we've done in Ireland. There will be good things and bad things. We're coming out of it. Our levels are going down. We're starting to open up society. We're trying to get vaccinations done. Certainly, data collection has been difficult. So we've utilized our strengths in general practice here. We would be highly computerized. We know our patients. And up to date now, with a population of 4.7 million, we have 1.1 million people vaccinated first doses. We probably have a fifth of that again on second doses. Half of that has been done in general practice. I can attest to the fact that it is bloody hard work, I can tell you, because you're dealing with COVID, you're dealing with non-COVID, you're dealing with vaccination, and you're reassuring people. But, there's hope because we are seeing less infections in our healthcare staff. We are seeing less infections in our nursing homes. And we are still seeing the development of vaccines. I think it is very important that we, again, emphasize that good communication in regard to vaccines. Although there's been concerns with the AstraZeneca vaccine, what we've got to realize is that you've got an 800 in 1 million chance of dying from COVID, while you've got a 1 in 1 million chance of dying from the most serious side effect of the AstraZeneca vaccine. So it's very important that we've got communication out there. You have a 1 in 1 million chance of being hit by lightning. So we need to be emphasizing, and dying from lightning, we need to be emphasizing the minimal risk of the dangers of some vaccine. And it's important that medical people take on those responsible engagements in the media, because very easy disinformation and this communication can be lost. There's also leadership issues in regard to vaccination. Greater majority of medical personnel in Dublin get vaccinated. It will less so in nursing personnel, but that's coming up now. And leadership in medicine and nursing and midwifery is very much important on showing that you have to do the right thing. The reason why we had the eradication of smallpox, the eradication of polio, is because of vaccination. The eradication of measles throughout the majority of the Western world is because of vaccination. So it is very important that medics who have a noble role in all of this, we're very lucky to have jobs. We have a dangerous job to do at times, but we need to be basically getting out there and educating people the importance of vaccination to protect ourselves and protect everybody else. That is how we're going to get past this pandemic.
Yes, that is a very key message. I will ask you, the last question that I have is the same one that I asked Dr. Kluge in the end, and I will ask that, I think, every panelist, so everybody can already prepare for that one. What would your key message to medical students listening in today be?
Maintain your health, first of all. Look after each other. Get your training. Don't jump in. Think. Get your education. Hasten slowly. The evidence is if we do all the basics, we can keep our infection rates down. We need to emphasize all of that, sort of maintain your health and look after yourselves first and foremost. In pandemic, you do not rush in.
Definitely. Thank you so much for taking the time. Thank you so much for answering all the questions. We have one request if we could share your slides afterwards, but we will be in touch through email, I think, and then we will figure that out. Thank you again for taking the time, especially with the next meeting being lined up directly after this one. And
thank you.
Yes, thank you so much.
Bye-bye from Dublin.
Bye-bye. We will move on to Matthias. Matthias is the president of the European Junior Doctors. So basically, after people have graduated and left EMSA, they move on to the EJD, if you can say it like that a little bit. Matthias is a medical specialist currently subspecializing in respiratory medicine in Karlsruhe in Germany. He has studied in Heidelberg and Luxembourg and was already active in the local students association, the doctors union in Germany called the Marburger Bund. Everybody from Germany will probably be familiar with that association. He's still an active member in the Doctors Union on regional, state, and national level, in the Doctors Chamber on regional and state level, and he is the president, as I said, of the European Junior Doctors Association, which represents around 300,000 junior doctors across Europe. Matthias will focus a little bit on the experience, after now having heard of the experience of doctors in Europe generally from Ray. We will now focus a little bit on the experience of the junior doctors in Europe, and I will hand over to you.
Thank you, Alexandra, and thanks to EMSA for the invitation to speak at this event. Shortly after I started preparing for this panel, I realized that with the topic junior doctors during COVID, I could probably talk for hours without diving deep in all aspects that this topic may cover. The roles and destinies of junior doctors during this ongoing pandemic are as diverse as the cultural landscape of Europe itself. I will try to cover some of the aspects that I see remarkable. Of course, on the darker side, there is without a doubt a new level of uncertainty that junior doctors had to face with the beginning of the pandemic over a year ago, with a highly infectious virus causing a new disease that is unknown, with treating protocols changing within days, and teaching programs, as mentioned, on hold, and few concepts on how to make up for lost time and lack of training. Some of my colleagues, for example, are already waiting for months to get their dates set for the specialist exam, and some of my surgical colleagues have not seen the inside of an OR for almost a year now. Especially in the beginning, there were shortages of proper personal protection equipment, with the risk of infection of oneself or the transmission to next of kin. And with suspended safety laws, with overtime piling up, and few concepts on how to ever even them up, stress was increasing. And unfortunately, you have probably seen the pictures of Italy, United States of America, or lately Brazil, with overwhelmed treatment capacities, with loss of life, of an exceptional magnitude and exceptional circumstances, without the time and the resources to deal with these experiences for healthcare workers experiencing them. And fear and lack of knowledge among patients led to verbal and physical violence against doctors and other healthcare workers. And it will take some time before we have a glimpse of the consequences these extreme situations will have on the medical workforce and what actions are to be taken to encounter them. I think the personal story told by colleague Alessandro Costa from Italy will highlight these aspects of the pandemic. Inverting a quote of Buddha, you may say, where there is shadow, there has to be light. And although junior doctors, as part of the many professions in healthcare, face difficult challenges with physical and mental strains, there are some positive aspects of junior doctors during COVID that I want to draw attention to. Despite all the negative aspects I mentioned before, junior doctors across all specialties and hierarchies rallied together to stand against the pandemic. During my time on the COVID ward, I worked side by side with pediatric surgeons and anesthesiologists, for example, and it was a great time. We learned so much from each other because we had the opportunity and the time to spend time treating the same patients. That's a situation that never has happened before the pandemic, and everybody was willing and is willing to bring his or her best. And I had a vascular surgeon with triple my time spent in medicine asking me if he could assist me with lines and drawing blood. So there was absolutely no professional pride anymore. The collaboration between colleagues to stay up to date and share the latest research and recommendations and to process it to be understandable to all professions, and that still lasts, is another positive aspect of this pandemic. And the joint fight against misinformation and alternative healing methods is unprecedented in my opinion, but at the same time, the negligence and the incompetence of decision makers feeding those currents is exhausting and demoralizing. And though training was and now often is again on hold, the way clinical and communication skills evolved during this pandemic is noteworthy. Try to get diagnostics with a highly infectious patients. You will probably not succeed. You are limited to the patient room and you can only use what you can bring into this room. That means often back to basic. And the physical examination is the main diagnostic tool you use on the wards. And one of my favorite attendings said that we are reclaiming a lost gift that was taken away from us by the technical diagnostics we use way too quickly and way too often today. Nevertheless, we need to find solutions on how to deal with impairment of training for all the junior doctors affected. As was mentioned before, the level of digitalization in healthcare is varying across Europe. In many countries, the pandemic has given a kickstart to research and development and put the need for new technologies into the spotlight. Things that were impossible in the past are possible now. Look at the digital meetings, like this one, that are now allow participation without the need to travel and stay away from families. Look at all the concepts evolving around digital patient charts connecting healthcare providers. I expect future generations of junior doctors to benefit from this evolution in a great way, especially when we bring our knowledge into this process and manage to be an active participant. SARS-CoV-2 will persist. Vaccines were developed and we will refine our treatment regimens to control the pandemic sooner or later. But I do not want to sugarcoat it. The pandemic has brought difficult challenges with negative impact on physical and mental health, as well as personal and professional development for junior doctors and other healthcare providers, especially during the first wave in 2020, when many of them were left alone with their experiences. Fortunately, many of the problems of the first wave are not present anymore, like lack of PPE, but as mentioned before, time will pass before we can see the total damage that is already caused. And the pandemic has painfully visualized the shortcomings of many healthcare systems. We will need to learn from this to be better prepared for the future and to be better and be able to protect our healthcare workforce better from those future challenges. It's a shame that the world needed a pandemic with so many lives lost and patients chronically ill now to draw attention to the healthcare sector again. Though being one of the fundamental pillars of our society, it's often underfunded and there is not enough investment into the workforce and equipment. Even worse, they're economically driven companies running hospitals that are making profits with sick patients on the back of their staff. And though being a doctor was and is my dream job, the conditions junior doctors are often forced to work in are one of the aspects of the old normal of junior doctors that I did not like. And I hope that we do not return to the old normal of junior doctors before the pandemic, nor stay in the new normal that we are in now. I hope that decision makers learn the importance of a functioning healthcare system that is not always running on fumes due to limited resources and relying on commitment and compassion of the staff. Following directives like the European Working Time Directive in all European countries would be a first step to take care of healthcare workers. Reliable working hours and reliable rosters are imperative to allow compatibility of family and career. And maybe some of the decision makers may think about profits on the back of the patients and healthcare staff and economically driven provision of healthcare. So I hope that junior doctors will be able to use the current momentum and help to create a new normal after COVID. Thank you.
Thank you so much. Are there any, I will first give a couple of minutes for any direct questions to what you've just spoken about before we move on to Alessandro. After that, we will have a couple of panel questions for you both to answer, which we have prepared. But so far, I don't...
If you would allow me to
Yes.
ask your question about the statement to the students, I would like to give one.
Yeah, go ahead.
Because I think that you picked the greatest job that you can have, and I hope you will enjoy it as much as I did, and I do. But as outlined, we will probably need a bit of a fight to create conditions that will not be a threat to our health in the long run. So what I want to give with you, whatever in medicine you do, you will probably find something that you can enjoy, but let's fight together to create conditions that we can work in without getting sick. Thank you.
Yes, now that you've said that, I think I will ask one question which was asked on the YouTube channel. I think it was directed at Ray, but I feel like it ties in quite well. So someone asked, because you mentioned work environment and you mentioned us working together. And I always say one sentence. I've said this, I think, at a bunch of panel discussions. I feel like the medical field is an organism. We have to work together. We cannot, one organ cannot, well, it can, but it doesn't really do a lot of good if just one of the parts of it works. So the medical staff or the medical professionals, the doctors can't work without the nurses working and vice versa. And we can't work without the pharmacists, everybody has to work together. So the question on YouTube was, there are some polls suggesting plenty, especially nursing staff, wishing to quit their job and re-educate to another job outside of the healthcare sector, I'm presuming. Can we tackle that issue on a European level?
The question is not can we, we must tackle it on European level. There is absolutely no alternative. We need to come together as different healthcare professions, because we're all aiming for the same goal, to provide best possible care for the patient. And that's another aspect. I let this out because I cut a paragraph of my little speech. But another effect of the pandemic was that you recognize what other professions bring to the table when it comes to providing care for patients. And it's not only the nurses and the doctors, but it's also maintenance, it's housekeeping. You need those little wheels, I call them, to have the big machine running. You cannot do it on your own. I think if I would be alone on intensive care responsible for patients, they would have a very bad experience with me, because I wouldn't probably find a vial of antibiotics. So we need to step together, and we need to step up together and fight for conditions that we can provide best possible care for patients. And I think it's not the question how or if, we must do it. Yes,
definitely. Okay, thank you so much. I don't see any direct, oh, do I? Yes, we do. We have one. Is in situations where fellow medical students are the ones who are not observing the COVID restrictions and others seem to be thinking of themselves, why should I if they don't? And how can we as medical students and doctors handle, I'm guessing, the fact that other people are not dealing with the restrictions in the way that they should be, let's say?
Well,
it's a very loaded question.
Yeah, difficult question. I think the first thing is to speak up and directly confront everyone who is not following rules. There are currents and tendencies in Germany and across Europe, I think, that are seeding misinformation and leaving the scientific path, trying. I don't know what their general aim is. I cannot imagine that there is a general aim. I think just people are scared and people don't understand. And sometimes we as professionals, we communicate too complicated to reach everybody. So my first thing would be to speak up. I have spoken up in the past a lot. I have been assaulted by a person in public transport after I asked her to wear a mask. It got kind of ugly, but I think it's still worth it, and I would do it again. So if you have colleagues not following, the first question is why don't you wear a mask? Please do it. So I would say speak up and confront them.
Yeah, that is very difficult. I had the same experience also on public transport. It wasn't nice, but it is very important. Another question we have before we move on to Alessandro and then we go to the panel questions, I would say, is from YouTube. So I believe we should be prepared to handle every kind of disaster that will happen in the future. The best way to cope with a disaster is to prepare by having a plan before it strikes. Do you think that a worldwide cooperation would be possible in order to create a plan?
Yeah, as Ray Wally quoted, prepare, prepare, prepare. It's the only thing we can do. We need to face that a lot of healthcare systems were absolutely overwhelmed with the challenges that we got, and it's not a question of if. We need to prepare globally, and the question is who can do it. I think the WHO is a very good organization, and I trust colleagues there to already have plans made up how to tackle this issue, because science has predicted that a pandemic of this magnitude will happen, and they already said it is not the last. Yeah. So we are forced to prepare, or we will end up in the situation in a few years. So I think everyone is aware, and I think the WHO will have the lead on this.
Definitely. Okay, thank you so much. We will move on to Alessandro, and afterward get back to you with our panel questions for this panel. Alessandro, you should be able to screen share if you have a presentation. I think you prepared something.
Let me try.
In the meantime, I will just quickly introduce yourself. So Alessandro Costa is a last-year resident in anesthesia and intensive care medicine at the now I will mispronounce this for sure. Do you want to quickly pronounce the university's name or the hospital's name?
So I work in Borgo Manero, which is a small hospital in northern Italy, and I'm a resident. I collaborate also with. Basically, that's my first slide.
Perfect. Go ahead.
Difficult.
Go ahead.
So I'm a resident, still a resident in my last year of training. I graduated in 2015, and I work at Simnova, which is a simulation center for medical professionals, students, nurses, and whole healthcare personnel. And also I work with CRIMEDIM, which is a disaster medicine research center, which focuses on both disaster medicine and humanitarian healthcare research and development. And I also collaborate since when I was a medical student with the European Master in Disaster Medicine. So my main focuses are on training and disaster medicine. And I had to put them up because it was too hard to define. I studied here in Novara, which is a 100,000 inhabitant city, and I work here, which is basically a really small town, but we have almost the same number of people depending on us. We have little less than 300 beds, but we have near us a rehabilitation center with over 300 beds, and we are the ICU for those people, so 100,000 and 600 beds. We have a small emergency department, 8 operating room. We have cardiac intensive care, but all specialties like endovascular procedure, cardiac surgeries, etc., has to go away. So we have also transportation on us, and we do a lot of deliveries. So we have to prepare for that too. And well, for us, pandemic started on February. And on March 1st, we had our first case. We knew it was coming. We started preparing. Our head of the department he works too with European Master in Disaster Medicine. Is one of the instructor. So we were kind of ready. And this was our first patient setting. We did not have enough PPE. So We started with what we have, and we quickly had to grow up. So in the first 15 days of March, basically, we just changed completely our ICU department. We set some areas which were available for everyone, and some which can you see my slide, by the way? Yeah.
Yes, we can.
Okay, which were restricted. We had to switch some rooms which were outside to full storage. When PPE started arriving, especially, they sent us some packages from China, which helped a lot in the early phases. And this was the situation where I started working. We had some knowledge. We trained people on the fly. People who never worked in ICU, which is a really difficult job. We had 6 beds, and all of them were appointed to treating COVID patient, and we just were full in less than a week. We had 4 beds borrowed us from cardiac intensive care for non-COVID patient, so we grew up to 10 beds. But it was not enough, obviously. So we went from 6 beds to 15 beds by converting our operating room, which had to be closed, to the bare minimum. We just went on with emergency surgeries, and everything which was not oncological or emergency had to be shut down. All the personnel was diverted to intensive care unit. All anesthesiologists or nurses had a small training, and we started. Up here we had our recovery room, and the picture below is what it became after 3 days of intense transformation. And while we were doing this, I got sick. I worked all my week with my head, and my biggest fear was, oh, damn, I might have infected it. So I started with some symptoms, and quickly I started desaturating, so it was not good enough. I see people reading on my ABG. It was not so bad, but I really felt it. I had a CT. I went to the emergency department where my friend worked and said, okay, we need to keep you here. And so I got accepted and admitted in the hospital. I stayed there for a week. I lost 6 kilograms in a week, even though my friend managed to sneak me a pizza. I kept my morale up, and after a week of intense doing nothing and feeling really depressed because I was not able to help anybody, while all my friends or my colleagues were in the trenches, I was there in the bed watching Scrubs again, and I was finally discharged after a week. Luckily, I just needed oxygen, nothing more. But then the hard part came, because I was home and I knew that I had to go back to work at some point. I was not able to do anything. I was basically desaturating while walking, still a bit. I was super weak, so I had to train up. First, we are Italian, so we like to eat, and this was our first concern. A friend of mine just prepared me a training sheet, and I did not have anything in my room. I was home quarantined in a single room. So the only thing I found out to exercise was a replica sword I had. So I started training my abilities and tried to get my mind back to work. I started studying a lot, so much that with a beautiful working group, we built some guidelines about COVID-19 on the management of thromboprophylaxis in patients. This work was really interesting, kept me up a lot, and our work group was really stimulating. After a couple of weeks, basically, I got tested and I was a free health. I was able to get back to work. And now the hard part, because first I was a resident. In Italy, when we are resident, we have a tutor which work with us all the time. So we have freedom of action, but we have someone overseeing us the whole time. Now I was hired. So this is my first day back to work. I had some freedom of action. This was my suit, but it felt like this. Because for the first time in my life, I was fully 100% responsible of my work. And well, therapies were a lot. We had some funding, so we finally had a thromboelastogram machine, and we were able to perform TAG to basically any patient. And so we learned how to read this test. So we did a lot of study. Also, our notes for patient, well, we started with 21 patients. When I was a resident, we had 6. And when we had 6, I was thinking, wow, it's hard to manage 6 patients. Now we have 21. So it was really hard, but the equipe was really good. They never let me down. They helped me a lot. So it was hard, but we got out of that. Also, just a side note, I used my phone, this is an advice, use your phone to keep notes, keep everything you don't remember. After the first wave, I had to replace my phone battery because I used it so much it depleted. And this was our first wave. But in Italy, we like a lot history, and we knew that it wasn't the end. So when the first days of September arrived, school opened, people started doing business again, and contagions rised again. But we were prepared. Our emergency department, our ICU were prepared. Our operating room were basically changed into ICU. And so we were ready for the task. Just to give you an idea of how much material this was, our trash after a 6-hour shift, we were throwing away like 2,000 syringes each day just to manage patients. We had new residents. We had very bad cases, but residents from the 3rd year got into 4th year, and so they got hired. We got new resident at 1st year, and many of them were students, medical students who were hired just after graduating and already had experience with COVID. So the morale was very high still at second wave. We were a lot tired, but we went on. And we managed also to increase our bed number from 6 to 28. We had 21 in the first wave. Second wave was really worse. The problem was that we had a third wave. And while in first and second wave, we have total population support, third wave was bad because people made healthcare choices a political question. And so a lot of popular disappointment on restriction, on lockdown went on. There were some cases of doctor and nurses' car smashed in the hospital parkings. Some creative thinking like sanitary totalitarianism went on, and they put it with 5G. So basically all the fake news merged into something new, and this is still a problem, and morale went down a lot. I took this picture, I live in a small town, I took this picture near my home. During first wave, many people had put a peace flag with written on it, everything's gonna be fine. And this is one of the most depressing thing I've seen. This was a peace flag with everything's gonna be fine, all faded, and just nearby a death mourning. And third wave is because it's not ended yet, really, really heavy on morale. especially when you don't have any more people support. Mental health is really important for people because they are locked down, and if they are not medical professionals, they don't understand what's happening in reality, and also for medical personnel. So having people helping you, it's really fundamental. This is a study a friend of mine, which she also had COVID while I was home, made, and they are working hard on mental health, especially for healthcare professionals, and we doctors were all included in those studies. I'm an optimist by nature, so we are having shots. I took this picture this morning. Vaccines are rolling out with some difficulties. We would like to have more. There is a lot of pessimism on some vaccines, but this has already been told, and we all got vaccinated, so at least we have less fear of infecting our friends, our family. Thank you. This was really quick, but it was a quick summary of my experience.
Thank you so much. I think that gave a lot of insights into, the personal experience. Just one question, did you get COVID once or twice? Because I wasn't sure.
I got COVID once.
Mm-hmm.
I got sick on the 15th of March, and I was free on the 10th of April.
Yes. Okay. Yeah, that is the danger for all the medical professionals, I guess, with being exposed to COVID directly. Thank you so much. We will take some direct questions which can be put into the chat. Because of the time that has progressed so much, I think we will move on to the panel questions directly, and the direct questions we will ask afterwards.
May I tell about, for medical students, we had a lot of medical students who were involved in the health process, mainly for contact tracing. And as soon as people graduated, they were involved also in ICU. We had 2 medical students who had their thesis in ICU, which they graduated, and basically the next day they got a job with us. And after 3 months, they were basically able to manage non-invasive ventilation, obviously with our help, but they learned quickly. Also nurses, many nurses graduated and the next day went into ICU or in normal wards, and they had really quick training and they learned a lot. Many of them stayed with us the whole time, and many now are full-time job in ICU. So keeping your mind sharp, even if you are not able to help, allows you to start working as soon as you can. And this gave us really a lot of help.
Yeah, that is a very good transition, because I have one more question for the audience, which I'm going to launch simultaneously while we discuss the panel questions. So just for the first one, I am positively surprised that not everybody is in COVID fatigue, that 9% have said that they do not experience COVID fatigue as much. I had expected everybody to would have said yes. But the next question that we have is about exactly that. So have you been actively involved in the care of patients who have COVID-19? Because I know that a lot of medical students, depending on the country, of course, have been actively involved. We have prepared a couple of panel questions. The first one you will notice is the same one that I asked Ray already. So we have recently noted the 1-year anniversary, so to speak, in quotation marks, of course, since the first case of COVID-19 was registered in the European region. What have we learned for possible future pandemics? And also, more specifically, what can we learn from cities such as Bergamo, where the numbers rose so quickly, so fast? I don't know who wants to take this question first.
Do you want to start, Alessandro?
If you want, I can start.
As you like.
So I really like history. So we have to watch the past and to learn from it to use it in the future. We had a lot of data from 1918 pandemics, and basically we are using the same ways to treat people nowadays. But we have one thing more that they didn't have, which is technology. Technology can help us really a lot. And having IT training is really, really important, because you can do research, you can build new tools to trace people, you can build new tools to manage infected, you can improve data management. So for the future, we have learned a lot from COVID, and we can still apply a lot of our new knowledges to this pandemic. And I'm pretty sure this won't be over with vaccination. As has been said, we had a HIV pandemic, and now we live with it. So is it possible? I don't know, I'm not an infectivologist, that coronavirus will stay in our future. We had 3 pandemics of coronavirus: SARS, MRS, and COVID-19 in the last 20 years. And when I studied medicine, coronavirus was basically 2 lines on my textbook. Coronavirus exists. There was a pandemic in 2001, point. Nothing more. So this virus mutates a lot, and we've developed many tools to understand and fight pandemics. So we need to use it.
Matthias, do you have anything to add? Or?
Yeah, well, I just summarized what has already been said. We need to be prepared, and that of course will cost money, because
yes,
if you don't have a strong public health sector, if your primary health care is weakened by budgetary restraints, then you end up where we are. So I think decision makers must accept that being prepared costs money, because you need to invest in your staff. And without doing that, we will probably be with the next virus faced with the same issues. So we need to prepare, and preparedness costs money.
Definitely.
Yeah, not preparing for pandemics is like buying a new car without brakes, because you don't use them all the time.
Yeah, exactly.
Alessandra, may I have a comment?
Yes, go ahead.
Thank you very much. As an intensivist, I wanted to say that in a scientific level, this pandemic of COVID-19 didn't teach us a lot of things, because COVID-19, when it is a severe situation, it's just an ARDS and nothing more, nothing less. The first thing is what Matthias said, that we must be prepared in order to support and to make better the healthcare system. The lack of ICU beds was the key point in this pandemic. And the slide that Ray showed us about the numbers of ICU beds in every country is a tragic slide. And I really don't feel very proud, because we are the second from the last, my country. Ireland also had problems, and I think that the financial support of healthcare systems is the only key in order to face and confront any pandemic. Thank you.
Yes, for everybody who doesn't know Marili is an intensivist in Greece, in Thessaloniki. We will be hearing a little bit more from her later on when we talk about ethics and about the refugee crisis. But feel free to jump in with the other questions as well, because I think that was a very valuable addition. The second question we have, I think, will also go a little bit into your work field, Marili, as well. So triage has been discussed as a method to prioritize patients in case of limited resources. It's been a discussion point, let's say, in the public sector, and also I know that in my university clinic in Berlin as well, it has been discussed. So the question that we have is this already being used in your clinics that you know of? And if so, what are the decisions based on? What are the factors that are being looked at when deciding where the resources go, so to speak? I don't know, Matthias, do you want to start?
Yeah, I may have a controversial opinion on that because I think we're already doing triage by prioritizing patients. It's not that we are thinking of triage. It's not that we're taking away care that someone already has, which most people bind to the word triage. But it's like if you're today are diagnosed with a T1, a colorectal carcinoma that is easily being operated and you have a curative option, currently you will have to wait for your treatment way longer than you usually do. And I think that we're already in that situation that we have to postpone curative oncologic surgery is a form of triage. This is my personal opinion I'm giving right now. This is not EJD. This is my personal opinion. I want to stress that because not everyone agrees. I think we're already doing triage. It's not out in the open because I think people would be scared if we say that it is. But if you have pre-hospital emergency services trying to find an ICU bed in a radius of 100 kilometers around their working spot, and they fail to find an ICU bed, I think we're already doing triage by not having enough for caring for critical patients and not having enough for patients that need timely surgery or timely diagnostics. So I think we're already doing it.
That is a very good point, yes. Alessandro, go ahead.
I agree with Matthias. We are seeing a lot of patients. In an ideal world, we would have unlimited beds, unlimited resources, and we could treat everyone like they deserve the best care in the world. Everyone deserves the best care in the world, but we cannot afford that. Especially in ICU, we have little personnel, very little bed. I don't know if you remember, but when they showed the number of beds of Ireland, where we were the next, so we did not have many beds, and we already had to treat them like they were gold. We had many patients who came to the hospital late because they had fear of getting COVID. I remember I personally saw a guy who came with a tumor the size of an orange who grew in the last 2 months from the thyroid, and he didn't came to the hospital to be checked because he had fear of COVID. These patients obviously deserve as soon as possible to be treated, but when there are people who might just have, I don't know, knee surgery because they have a little pain in walking and they are just home, well, we can postpone that for a couple of weeks because we need the anesthesiologist and the intensive care room and the bed and the operating room for keeping alive 2-3 patients while he just can keep having paracetamol once a day. This is really bad, but disaster medicine teaches us to do the most for the best for the most. And obviously, in an ideal world, we won't be doing that, but we are already doing that.
Definitely, yeah. Marivi, do you want to add anything?
Yes, I just wanted to say that we are all aware that there are guidelines for people who have the right to be transmitted in the ICU. And those guidelines exist many years ago, and they are in the European Society of Intensive Care Medicine and the International Society of Intensive Care Medicine. Of course, there are guidelines, but I think that there is a danger when we say the word triage, especially in this very moment in the pandemic, because people, population, and the media can take advantage of this word of triage. So we have to be careful when we say the word triage during this pandemic. And of course, I totally agree with Matthias that people who have a cancer and can be operated, and probably they might need the ICU for just a few days, they cancel or they postpone all these procedures and the operations. This is the large explanation of triage. But if we use this word now during the pandemic, a lot of misunderstanding is going to happen, and the media are waiting for us. They applaud us, the healthcare workers, but in the other side, they are waiting for us to slide a bit and then to condemn us. So I think we must be very careful with the word triage now.
That is a very good point. Yes, the external image and the consequences of what we say, that is something I think that also for medical students is extremely important, because people look at the students as if on one hand, they're not yet professionals. On the other hand, they're close to being professionals and take what think words are sometimes twisted. I have also observed that, or can be twisted, especially that is a very good point. We have one last panel question that I wanted to ask you, and I think we will go to EJD, so to you, Matthias, first, because it goes into the mental health issues. Again, the same question I asked Ray as well. So how can the mental health capacity of healthcare professionals be more protected and the effects of the pandemic mitigated? I know that that EJD has been looking at the mental health issues and burnout amongst junior doctors as well. We have also been looking at the students, but from your perspective, what would you say could be done?
Well, I'm repeating myself now because it's always the same. We need to have enough resources to deal with the challenges that we face, because burnout often is accompanied by loss of control, by loss of your working hours, by loss of your schedule, by loss of how many patients you have to treat, by the amount of patients you lose. And the circumstances of this pandemic all bring these factors to the people, and we assume, as far as I know, we have no reliable scientific data at the moment, but we assume that the COVID-19 pandemic will have severe effects on the mental health of the workforce. And as said, preparation. We will fight for regulations like the European Working Time Directive to be implemented in every country and to be monitored and sanctioned if it gets violated, because this is the first step to care for your healthcare workers, to give them back kind of control over the time they need to work, over the hours. And there needs to be a safety net that if the next pandemic comes, we are not at the same position that we're short-staffed and unprepared. I think we need to be in control. We need to be as much in control of such a situation as we can be. And this is my opinion again. I think we were not at this time.
That is a very good point. Does anybody want to add on to the question of health issues? If not, we can move on to the questions from the audience, because we have one I think that would be very interesting for us to ask to you, Alessandro. In conclusion, how did COVID affect your training as a medical professional?
COVID affected a lot of my training. I was given early responsibilities, and this also stimulated me to study and prepare a lot. So I might be controversial, but COVID improved my training. Working with residents and medical students, I might say this is not the same for everyone, obviously, especially for medical students who got their, especially the last year medical student in Italy got their leg cut because they were not able to join many medical practical rotation or training in our simulation center because of restrictions. Obviously, most of the training depends on yourself. I mean, if you want to be training something, you grab yourself by the ear and go and get a training. You follow a seminar, you go in the wards, if you are able to, obviously. If you're not able, you try your best. Those who didn't want to improve before, didn't improve with COVID. Those who wanted to have a big part to help to grow, they had plenty of opportunities. So, and many of them grew well beyond what it would be their level after being medical students.
So a lot of intrinsic motivation. That is a very good point. Last but not least, because I know that we're already way over time, but one question, because you already answered the question of the message to medical students. Someone asked something which I think can be put into the same context. So someone asked, how do the both of you in your clinical duties deal with the mental strain? Are there any coping mechanisms that you could recommend, for example, also to our, let me quickly check, to our, actually only 12% of people here are working in the wards as well, but also for the medical students who will be starting very soon or who are already working there. Do you have any tips or tricks on how to protect one's mental health?
I think Ray said it, that we are all human, and that's the thing we need to accept at first. And that's why I always say speak up. If there is anything, speak up, and speak up early, and care for your peers. Go to people and ask them, hey, I heard you had a terrible experience. It's like the 5th death in 2 days. Are you okay? Or probably he or she is not okay, but try to provide help. And the responsibility is with us all to care for each other. So that would be the same as with the masks. The first thing is always to address it out in the open. You cannot deal with it when it's inside someone. So I just want to encourage everyone, care for each other. Just ask. If this is, no, I'm fine, then you have done everything you can.
I can just agree. I mean, I work in ICU and we see a lot of bad cases, and some of them go really bad. It's okay to have a bad day, and you need to take it out. You need to have your own timing. You need to have your own safe mental places. You need to do what you like. When you are out of the hospital, you need to keep your mind sharp. You need to study, but you need also to relax. You're all human. It's okay to cry. It's okay to have breakdowns. It's normal, especially in those times. It's way worse if you just get it and it grows till you explode and you can't take this job anymore because you wasted your mind, you wasted your time, and you risk doing not your best to your patient. Have your safe mental place. Do something you like. Ask if you have a girlfriend, a boyfriend, your friend, your family. Maybe they might not be clinicians or healthcare professionals, so they don't get what you are passing through, but they're all humans like you, hopefully. So in this situation, they could help. Even if they don't understand your work stress, they can understand you. And this is really important.
Yes, definitely. Thank you so much. So unless there's anything, do you want to add anything to the medical students, because you already answered that question? If not, then okay, I don't think so. Then thank you so much for joining us.
Thank you so much.
And have a great day. And yes, there was really truly valuable input. We are a little bit behind schedule. We will continue at 1 p.m. with the first panel on the second panel on the ethical aspects, and afterwards focusing on vaccinations. We welcome you back here then. The first speaker will be Ottmar Kleuber, the Secretary General of the World Medical Association, followed by Marilie Pasai-Kyoto, who you've just met as well, who will speak on the refugee situation, the situation specifically in Lesbos as well. Thank you so much, Matthias and Alessandro, and enjoy your weekend.
Thank you for having us. Have a great rest of the event. Unfortunately, I need to leave now. Thank you. Have a nice weekend.
Bye-bye.
Thank you. Have a nice weekend.
So I will just quickly put on the screen for the break, and we will see each other at 1 p.m. sharp. Okay, it's 1 o'clock. Welcome back, everyone.
Hi, Alexandra.
Hi. So the
Zopa.
microphone's working. Very good.
Yes. You still have to release the video stream.
Yes, I did. It should work.
Yeah.
Hello.
Here I am. Hello. Hi there.
Okay. Marie-Lie, I don't know. Perfect. Okay, everyone is back. Then we can go on to the second panel. I hope that everybody enjoyed the very short break because we're a bit with the time. I had to cut it down a little bit. I do apologize to everybody watching. We will now move on to the panel discussion focusing on the ethical aspects of the pandemic. And here with us today, we have Dr. Ottmar Kleuber, who's the Secretary General of the World Medical Association. He was the Deputy Secretary General of the German Medical Association before going into the position of Secretary General of the WMA in 2005. He holds an MD and a PhD from the University of Cologne with a postdoctoral fellowship in the Department of Biochemistry at the University of Minnesota, and was a scientific research assistant at the Max Planck Institute of Neurological Research. He holds an honorary doctorate by the University Victor Babeș in Timișoara, Romania, and was appointed clinical professor in health administration at the Brooks College of Health, University of North Florida from 2009 to 2013. Ottmar, I'm giving the floor to you. You should be able to screen share if you want to.
Yes, I will. Thank you very much, Alexandra, and thank you for bringing together this very interesting discussion on the new normal. And let me say in the beginning, I'm not yet knowing what the new normal will be. I guess we all can only guess and have some ideas, but I think the picture is still developing, and I think some of the analysis you have heard, the very excellent one from Matthias, the optimistic outlook from Dr. Kluge, but also some of the very serious reports from Dr. Costa, for instance, we have heard, show that this is a very, very difficult and complicated picture, which we still have to learn with. And by far not all is medical. As Marie-Lie said, you know, it's a pandemic. That's not the first one. We have seen a lot of them, but we have seen a lot of the political, social consequences of that and economical ones, which we have to deal with. And you have asked me to speak about the ethical challenges. Now, I cannot give you an exhaustive picture of that. Some is because of the time that I have. Some is because we still don't know all of the ramifications. And so it's just a very personal selection that I will do. But I guess for most of it, everybody will be able to agree with the selection I have been taken. Just a few words about the World Medical Association. It was founded in 1947 after World War II. And with a view of the abuse of medicine, especially in my own country, in Germany. And since then, the World Medical Association is the global platform for developing the medical ethics, the deontology, but also we deal with social questions in medicine, with educational questions together with the World Federation for Medical Education. And we closely cooperate with the regional organizations like the CPME, which is a very, very close and well-working partner with us. And the WMA, of course, has been looking into this question of emergency and pandemic preparedness, especially since 2005, very intensively. And like WHO, we had the same messages. It was very clear that something like this would happen. Everybody has said this, but only few have really reacted, and that's a little bit sad. So let's have a look on more on the ethical questions here. As I said, it's a non-exhaustive questions. I have no conflicts of interest to declare for this. I'm not a politician who's dealing with PPE and getting money for it. With the ethical challenges, I would like to focus on those which are directly affecting us and where we have to deal with as physicians or as health professionals in general. And of course, the first and premier thing is the question about distributive justice and equity challenges that we have seen. And they are numerous. There's not one equity challenge, there are many of them. and I will speak a little bit more in a second. I would like to speak about human rights and personal freedoms, which are ethical challenges in this pandemic, but also complacency. And it's not only complacency by others, it's also complacency by us, which we have to deal with. I will not speak about the political failure that we have seen, the greed, ignorance, corruption in the political field, which was astonishing to me in which extent we have seen it during the pandemic. And it makes, I guess, everybody, Matthias said it already, it makes everybody a little bit depressive and frustrated and disappointed about the bad performance which we have seen from our political, often many of our political leaders, not all, but many. Coming to the questions of distributive justice, there are not only local, they are also global. Usually there are about unequal distribution, not only of the incidents, but then also of the supplies of the medical care that we have. We have seen that usually the working class, for instance, has a much higher incidence because of their type of work they're doing. They cannot be isolated. They have to cooperate. They have to physically work together very close. We have seen that there are many groups which are disadvantaged. We will speak about refugees a little bit more, but the same is true for poor and homeless, which we also have in our countries, in all of our countries, which are without protection and pretty much left alone. On the other hand, we have seen that wealthier people usually can afford better means of protection, whether that is better isolation, more PPE that they can afford, or they have better education to know better what can be done and what should not be done. So in general, we also have seen that poor communities, whether it is on a global or on local scale, have less chance of protective behavior and also protective means. We have very big challenges on access to healthcare and access to vaccination. And those are 2 points I would like to go a little bit deeper into. When it comes to the access to medical care, we have all the questions of who gets what. It starts with the access to testing. Is that really available for those who need it? What are the rules for the testing? In some places, it seems to be very random. I have not seen that one of the Western countries, at least, has done really a program on testing comprehensively in a way that we really can measure the pandemic. It's more randomly what we do, or by accident, to be more precise. Same is true for the treatment, who gets treatment, who doesn't get treatment. Again, is there an equity question? I would say yes, there is. Not only between countries, also between in the countries. Depends where you live, how good the treatment is, how good the access to primary, but also to tertiary care is for the COVID. When we talk about intensive care, there are huge differences in the number of intensive care bed per population, depending on where you are living. And that is a political, it's not a medical question that has been taken there. So treatment options. And then the triage, which comes up, are things which are now really posing a problem to all of us. And they are not only posing a problem now, they should have posed a problem before, because what we have saying all the time is you have to have triage rules in place long before the pandemic. Matthias is right when he says, we are taking these decisions already in our everyday life, and we have done so before the pandemic. Now, what I would say is this is a type of rationing that we are doing. The triage is a term that is especially used in the times of emergency, where there's an overwhelming emergency which really crushes on our resources. And there is a deep, sharp demand for the resources or lack of resources in that moment. Indeed, the borders are fluid, and I also would agree with Mary Lee. The term triage is a very difficult one, and I'm not sure whether it's always helpful to use it. So I also would argue to use it very cautiously. But it needs preparation, and it needs preparation before a pandemic and not during a pandemic, or when you're already in the situation that you have to take these very difficult decisions there. I would like to come to the question of access to vaccination. Here, again, we have questions of equity. not only with the distribution of the vaccination and the prioritization rules that are there, where you can ask questions: are they correct? Are they fair? Are they really helpful? Are they medically indicated, or are they socially indicated? For both, there are good arguments, but I think the arguments have to be dealt with in a very transparent way and in a fair way. I'm not sure whether that is always done by self-selected groups who then take decisions on that. Those are questions which, again, should be discussed upfront and should be also prepared upfront. I'm not saying that the actual way of how you vaccinate, how you treat and how you test can be decided always upfront, but there should be a preparation for it so that you have the tools and the means in your hand when actually the situation comes. And then there are many questions when it comes to the equity and distributions globally on the vaccines. We are currently stuck in a system of industrial ownership of IP rights, which are made for a machine industry 200 years ago. The question is, are those IP rights still the right ones, which we have? Don't we need to think about it? Also with a view on the fact that a lot of investment has been made in vaccine development by states, by governments, by research institutions, by public research institutions. And where is their part, or is that part that we all have invested in that when it comes to the use of those vaccines and how they are being distributed? We have ethical challenges in the field of human rights and personal freedoms and restrictions that we have seen. We all are suffering from the limitations which we have on our movement, on curfews, contact reductions that we have to take. We have a limitation of essential rights, and running around without a face mask is not an essential right for me. The essential right is, for instance, the right for education that our children have. How can those be limited under a view of public health? And it is a public health question what we do. That is something that we have to discuss, and we have to be involved there as physicians. There, it's not our decisions, but it's certainly one where we should play a role and have to play a role. And there's infection control, what we can do and should do in order to restrict the infection. There is the question of civil conscription. We have heard that in some countries, students are being forced to do work with COVID-19 patients. Now, I think dealing with a pandemic is part of an education, but it has to be done under supervision by not endangering students and not by abusing students as cheap labor. That's not part of an education. And education itself is an essential right that should be fulfilled, and which is necessary in that case in order to be able for future generations to deal with pandemics. But civil conscription is then a problem, especially when it is being selectively used for professional groups and not for a whole population. And there's something which are ethical questions behind that. Again, it's a question of equality and equality that has to be dealt with in this context as well. We have the isolation of vulnerable groups, and we all know these pictures and have them in mind of isolated old people, which are basically robbed of their last years of life because they are locked away, which I think is not the right way to deal with the problem. It has started with a sick language which we are using, like speaking about social isolation, which is one of the worst nonsense I've ever heard of. We don't want to isolate socially. We want to have a physical distance and not a social distance. But using these wrong terms then also leads to products and to behavior there, obviously, which is completely unacceptable. So we need to have better protection of vulnerable groups, and to deal with this in the future will be a big challenge, and not to repeat the same mistakes of really locking away old people or vulnerable groups there. We have the questions of mandatory testing and mandatory vaccination, which is before us. And we also have to deal with the question of resetting privileges once somebody is fully vaccinated. What can they do, and how can they gain back their rights as civilians? Finally, a word about complacency. Complacency is a problem because most in our Western world, we have not been prepared for the pandemic. It has been said that it will come. It has been said by WHO nearly on a monthly basis. It has been said by us, but we all have not really prepared. In the rich countries of the West, at least, we have done nothing except for some paper exercises, which were ending up in some drawers. But there have been no pandemic drills. There has been no stockpiling of goods for that. Instead, what we have is we have a complete shift of the commercial organization of our healthcare system to lean production, just-in-time production. Instead, what we need is just in case preparedness for our healthcare system. So the commercialization, commoditization of the healthcare system is one of the big political mistakes that has been made, which certainly now has cost many, many people lives in our healthcare situation, which we have right now. And the same is true, maybe even worse, for the understanding that we have of our public health services, which have been dried out completely. The lack of digitization, which now is picking up, has been already mentioned for that. So the only conclusion I have here is this should not happen again. We must be better prepared. And I think to that extent, I completely concur with the previous speakers. Back to you, Alexandra.
Thank you so much. And I mean, there's also, I listened to one of the speeches you gave, I think at the UNESCO Bioethics Conference, and you had a very good simile to the boats. And that stuck with me for a while. I don't know if you maybe want to share that. I thought that was...
Yeah, it's not my own quote. I have quoted it from an American writer. We have heard the same this saying that we are all sitting in the same boat with the pandemic. That's not true. What it is we are in the same storm, but some of us are sitting in very nice ships, on yachts and very safe boats, and others are on rafts or just drowning. And that is exactly the picture that we have right now, is some people are dealing in a very safe mode with this pandemic and are pretty well off. Some even taking benefit from it. And others are really drowning and are being killed with this pandemic because they have no means for protection, they have no medical care. So the pictures which we are using are sometimes very distorted. And I think this was a very nice image to put it right, and saying we are not in the same, we are in the same storm, but we are not in the same boat.
Definitely, yeah. And before we move on to Marie-Lie and the societal group, that definitely, the boat simile is very appropriate there, if I may say so, because that is just the reality that, that Europe is living in at the moment and has been living in for a while, and still with no foreseeable way out. I just want to quickly give everybody a quick chance to ask some direct questions to your presentation. So far, we haven't received any, or you can also continue to ask those while throughout the next presentation, and we will then move on to the panel questions. Thank you so much for that input, though. I think that's I think that the ethical aspects are a very important. It's a very important aspect which a lot of people neglect oftentimes. So we focus a lot, especially in the medical field, on the actual situation in the hospitals, which definitely is important. And now we've recently started to focus also on the mental health consequences, which are just as important in my opinion, but the ethical aspects and specifically the simile with the boats is something that I feel like is not being looked at. And that's something that stuck with me after your presentation at the UNESCO Chair and Bioethics Conference for a while. For a lot of weeks, I kept thinking about it. So thank you so much. Marie-Lie, do you want to?
I didn't hear you.
Oh, sorry, I muted myself. Do you want to continue? I will share the presentation. Feel free to start.
Okay. Well, thank you very much, Alexandra, and thank you very much for this very kind invitation.
Sorry, before you start, my mistake, I completely blanked for a second. So because we've been speaking for a while now with you as well, I didn't introduce you in the beginning because I thought I'd do that now when we get to your presentation. So Dr. Pasakiotou is a surgery and intensive care specialist working as an ICU director in Thessaloniki in Greece. She's also a member of the board of the Pan-Hellenic Medical Association and a representative of the Pan-Hellenic Medical Association in the CPME, and also CEOM, which is the Conseil Européen des des Ordres de Médecins, and also in the Association Européenne de Médecins de Hôpitaux, so AEHM. She's furthermore an active member of the Board of Professional Qualifications at the Greek Ministry of Education, and also the current CPME Rapporteur on Refugee Health. And we're very happy to have you here today to talk to us a little bit about the situation, specifically in Lesbos.
Thank you very much, Alexandra. The honor is mine, and I really have a great pleasure to participate in a symposium where the audience are young doctors and students, medical students. It's a very fruitful symposium, this. And of course, I might go with the theme that I have to present is that it's another aspect of the COVID-19 pandemic. You all know that in Greece we have a great problem with the refugee crisis. Next slide, please. Just to remember, in 2015, we had the biggest flow of refugees, especially from Asia and from Africa, of course, but the majority was from Syria after the war and Afghanistan. And the gates where refugees entered the European Union and Europe generally was mostly from Turkey. And as you can see the numbers, it's almost 1 million of refugees, immigrants, economic migrants who tried to enter European Union by the islands of Greece. Because of this geographical place of Greece, it was the first gate of entrance. And in 2015, it was really a refugee crisis in a country where the financial crisis was also apparent. Next slide, please. As you can see the map, this is Turkey, and these are the islands who are very close to the coast of Turkey. And this is the island of Lesbos, which was the island where the majority of refugees were stranded there. As you can see here in the map, it was more than 500,000 of people who entered this island. Next slide, please. It's just a picture, and you can understand all those life jackets were left in the coasts, and there were a lot of NGOs who tried to help because the country was not prepared to accept this flow of refugees. Though 81 NGOs were present in Lesbos, more than 500 NGOs were present in Greece, only 31 were officially registered. And this was a problem because some of the NGOs not officially registered made more harm in this situation than they offered something good. So the Greek government was forced in February 2020 to enact a new law in order to improve the monitoring of the NGOs. There were a lot of reactions against this law, but there was also problems created by NGOs who were had the cooperation with the smugglers in the transportation of illegal migrants and refugees from Turkey. Next slide, please. Just because it was a huge problem, there was an agreement between the European Union and Turkey signed on March 2016. Next. What was the goal? Next. To end irregular migration from Turkey to the European Union. Next. How this could happen? Next. Turkey would withhold the majority of refugee influx. Next. In return, the European Union would deliver the long promised but never delivered visa-free travel for Turkish nationals within the Schengen zone. Next. And provide 3 billion euros just for 1 year in financial assistance to support the 3 million refugees living in Turkey. This very moment that we're talking, it's more than 4 million refugees living in Turkey. Next. And of course, reinvigorated Turkey-European Union accession negotiations. Next slide, please. The results, there were good results. As you can see here, in 2015, the influx was more than 1 million. In 2019, it's 100,000 people approximately. And of course, there was a good result after the signing of the European Union-Turkey agreement. Next slide, please. The current situation, it's updated April 11th, 2021, is this. As you can see, there are not a lot of people who are coming. This is from the United Nations for the refugees, and it's every week they publish this map. As you can see, there are not a lot of influx in the islands. And in this table, you can see what happened in 2015 and what happened in 2020. And the red numbers are the dead and missing people in this area, only in this area, in the Eastern Mediterranean, not the Central Mediterranean or the West Mediterranean. It's 800 people were lost in 2015, much less in 2020. Next slide, please. Now, the population of concern in Greece has to do with refugees, asylum seekers, and others, and they are included unaccompanied children and economic migrants. And as far as concerned the refugees, most of them are from Syria. As far as concerned asylum seekers, most of them are from Afghanistan. Next slide, please. This is the Moria camp in Lesbos. We can focus now in this island, which has the most difficult problem to confront. This was the Moria camp in Lesbos. And next slide. In September 2020, there was a fire. We don't know who are the guilty. Some people were arrested. Some people between refugees were guilty for this fire, but nobody knows the truth. Next slide, please. It's just pictures. You can go on forward because it's just pictures to show what happened in this camp in Moria. Next slide. Next slide. This is what happened in Moria. So, after this, 12,000 people became homeless. Suddenly, in one night, in a small island of Lesbos. Next slide. They created a new camp, a new hotspot in Mavrovouni, very close to Moria, which the capacity of Mavrovouni is more than 6,000 people. Next slide, please. Which is the current situation? Yes. Thousands of refugees and asylum seekers are living in tents on the islands, except Lesbos, Samos, and Chios, who are very close to the Turkish coast, and had to endure with different climate problems, low temperatures and winds. Next. Conditions in detention and reception centers and camps remain difficult. We cannot say any lies. They are overcrowded, those camps, and it's difficult, the access to clean water and sanitation. Next slide. Of course, from the very first moment, the asylum applications in Greece were very low because people wanted just to pass through from Greece and go to other countries in the European Union, especially in Germany and in the Scandinavian countries. And in the first year, of course, Germany was the first country who accepted 500,000 of refugees in their territory. But in Greece, they were very slow, the asylum applications. Now with the pandemic, of course, they are much less. Next slide, please. Yes. Access to asylum remains complicated because of legal difficulties. Next slide. Next. Next. And of course, the reunification procedures have also put on hold due to the pandemic. COVID-19 shutdown measures have significantly hampered access to education. There was a lot of programs supported by the government and by some NGOs, official NGOs, and there was a program for education for children of refugees, and now this is very difficult to be applied because we have the COVID-19 shutdowns, and also teachers cannot go there in order to support the program. Next. Unfortunately, and I'm not very proud of this, incidents of hate crime and hate speech targeting migrants and refugees have been reported. There were a lot of incidents in the island of Lesbos and in the other islands, also in the mainland of Greece, where people are now lost the ancient feeling of hospitality in Greece, and they have a lot of anger against refugees and migrants. Next. What happened with COVID-19? COVID-19 pandemic added a complexity to the reception crisis management, as you can really understand. Then they have extensive lockdowns and restrictions of movement, as all the population in Greece has a very strict lockdown. These influence the daily lives of refugees and have hampered the efforts of humanitarian workers. Next. Of course, we have very few new arrivals. Next. And of course, the relocation program to other EU countries has increased in difficulties due to the pandemic. Next. Fortunately, there were limited COVID-19 positive cases inside camps, and only one death has been reported amongst the majority, the more than 70,000 refugees and migrants in the whole country. Next. Another hotspot at Karatepe, which is closer to Mavrovouni in Lesbos Islands, there are only 14 individuals now in quarantine and no one is hospitalized. And according to the authorities, there have been no newly confirmed COVID-19 cases at the Mavrovouni since Christmas, and no people are in quarantine since March. This is a very good result. And the government transferred from overcrowded island centers to a safer accommodation more than 2,000 immunocompromised individuals. Next. So, Greece's government is leading the prevention and response to COVID-19 with the full inclusion of refugees and asylum seekers in the national health surveillance, preparedness, and vaccination plans. And I have to comment here that there was a survey in CPME where we were asking what is the access of refugees and migrants in the healthcare systems of the countries they are living. And one of the countries that gives full health care in refugees and migrants, I mean primary, secondary, and tertiary, is Greece. It's something that we have to note. Next slide, please. COVID-19 pandemic has verified the fact that the most vulnerable are also the most exposed, and that in times of trouble and discrimination, injustice and inequalities are amplified. Next. Consistently and continuously, asylum seekers and refugees in Lesbos and Greece are confronted with daily survival challenges, threatening situations, feeling frustration, and fear regarding an insecure future. That is the truth. Next. The only progress announced with regard to the migration landscape in Greece has been the creation of new closed centers of accommodation. And we will explain why happened this. Next slide, please. Moria has been the symbol of the failure not only of deterrence policies, but also the symbol of the failure of the European Union attitude towards the refugee crisis. Next. People in camps on the islands and in the mainland remain in dire need of assistance. Next. And so are the people that are sheltered to alternative accommodation sites. Next. 6 years after the peak of arrivals in 2015, refugees and migrants stranded in Greece continue to be in need of a multi-level support, in need of humanitarian assistance, of access to necessary services such as health and education, and in need of a realistic, sensible, and humanitarian plan. Next. By February 2021, Greece has improved significantly its asylum and reception systems as compared to 2015. There is a new system now in Greece and the government with not only telemedicine, but it's digitalized. A lot of public services are digitalized. So this helped these procedures for asylum and asylum applications. Next, please. Efforts must now be focused on helping refugees integrate effectively in Greece. Here I have to comment also that there was a struggle from CPME in order to find out a common language in order to integrate effectively first of all, refugees who are medical doctors in their countries, and to find a common way to legitimize their documents, their diplomas in medicine, in order to help, in order to work in camps first and help their compatriots, and then to be integrated in the societies where they asked for asylum. It was very difficult to find this common language because all national medical associations of the European countries have different rules, and we couldn't find a common rule in order to documentate the diplomas, the medical diplomas of refugees who happen to be medical doctors in their countries. Next, please. And of course, such a program should promote refugees' self-reliance through empowerment of refugee communities, support from governmental and municipality authorities, as well as concurrent integration projects driven by public or private trusted organizations. Next, please. These are the documents that the Working Group on Refugee Health made through the 3 years mandate, and these were had to do with the criminalization of acts of solidarity, with integration, etc., etc., etc. It was a great job that we have done in CPME. Next. Concluding, this is the island of Lesbos. And this is a picture, this is a photo that happens. It's not happening now because of the pandemic, but happened all those years before the pandemic was apparent. Thank you very much.
Thank you so much. I thought that gave an incredible insight into the situation, one that we normally don't get. I, for one, for example, also wasn't aware of the exact specific deal, so to speak, between the EU and Turkey. I knew about the money aspect. I did not know about the visa aspect that originally was included. So that was very interesting to me to also hear. We got some questions for you, Marilie, in the Q&A section. So the first one, I mean, it also already, I think, goes a little bit into our panel questions, but are the refugees being currently vaccinated in Europe?
I'm not aware of that. I don't know.
Okay. And do you know of some steps taken to treat refugees who are affected by COVID? Are they being implemented into the national just hospital treatment normally as any other, or is it?
Yes, exactly as the other people, as the rest of the population, just the same. There is no discrimination against them.
That is good. That is good to hear. Another question is, what do you think has to be done in general to improve the conditions in the refugee camps, especially from a political or European standpoint?
You know, I said that I will comment something later. It is one of the panel questions, but since somebody, Lara, asked this, I have to answer that the only solution is not to have the overcrowded camps. You have to know that after 2015, there was a commitment from the European countries signed that they would accept refugees proportionally according to their population. But this was never happened. The only countries who fulfilled their commitment was Finland and Malta, very small country. And of course, Germany was a country who accepted a large number of refugees. Since the other countries have borders, and you all aware of 2015, 2016, the borders and the wires and the fences that they created in different parts of Europe, and the refugees were stranded in Greece and they couldn't move because there were the wires and the police and the army in different parts, in different frontiers of the northern part of the Balkan route from Greece. So all these people were overcrowded in the camps. Since there is no acceptance of the other countries to take a large number of the refugees, we cannot make better the conditions in the camps. No matter how much money they're going to give us, it cannot make it because the area has some squares, meters. We cannot do something more. And of course, Greece is a very small country, just 10 million of people as population, has the financial crisis, has 3 memorandum, and was obliged to face this refugee crisis. It's the other countries who deny, who refuse to take the number of refugees. So this is the reality.
That is a very good point. Something that also a lot of people actually at the moment, it's not being discussed again because the focus is being shifted to the pandemic. Another question that we have is, one second, how can authorities prevent the vaccines from becoming a political instrument? For example, with some countries accepting the Sputnik vaccine from Russia, while other countries deny them, are there measures being taken? I think that's something maybe that Otmar, you can also, if you want to focus on, because this is not specific to the refugee crisis, so we're shifting to general questions now, sorry.
Yeah. Thank you. I think what we should do is we should strictly separate any political discussion from the medical discussion. And what I would like to see is that there is a fair testing or fair scrutiny of the COVID of the Sputnik V vaccine in Europe, and then that it has been admitted, if the criteria are fulfilled, which I hope they are, that it is admitted as any other one. And that this is then not a commodity that is being used to make political statements against or in favor of any system or any partnership, or to undermine any partnership. I think that would be a completely wrong signal to do that. What I'm wondering about is indeed that the uptake of the vaccine itself in Russia is not that good. So the vaccine hesitancy in Russia is very strong, and I think Russia itself has a big problem with that. That is, to me, a very worrying factor. Otherwise, I think treat it as any other vaccine, and that's true for each of the European countries. It should be included in the canon of drugs that can be used as soon as the market authorization by the European Medicines Agency is there. And I'm pretty sure the EMA will do its best to do a completely fair and correct treatment for that product as for any other products.
Yes, we have someone from EMA here right now as well. We will move on to the accreditation process and the rolling review in a little while. Thank you so much for that answer. I think that's the Sputnik vaccine. There's a lot of discussion, as is with AstraZeneca right now, or with every single vaccine pretty much. BioNTech is actually one of the few ones which is not that much scrutinized, or that highly scrutinized right now. I have two more questions on the refugee crisis specifically. Afterwards, I would say we would move on to the panel questions in general, and then take some general questions in the end again. One of them is, Marili, is the Greek society able to integrate such a large amount of, or such a large number of people in the camps?
Not all the number, not the number. Yeah, it's a very large amount, but some of them, yes, they can be integrated.
And how do you think that, I think this is a very difficult question to answer, but how do you think the integration will work without generating more hate from society and without impairing the country's current population in terms of employment, for example? That is a very complex question, I think.
I think that diplomats and politics didn't answer that, so yeah. I'm not able to answer to this question. It's a very difficult question. It has to do with the mentality, it has to do with the education, it has to do with a lot of parameters, and I am not able to answer that, since governments and diplomats didn't answer this question.
Yeah, go ahead.
There's a very interesting observation from Germany. You know, we have these different lenders in the different parts of Germany, and it is quite interesting that the biggest obstacles and the biggest adverse reaction against refugees is in those parts where there are the lowest numbers of refugees. And that to me is still a quite interesting figure, and we have to ask why that is from. So quite obviously, there is not a causal relation between taking up refugees and getting adverse reaction. There is something else that is in between, or is within the society, that produces this kind of xenophobia that is with this anti-movement. And I think there has not been enough attention paid to this fact. Thank you.
I totally agree with you, Otmar. It's the mentality of the country, and Greece is a country that, of course, the mentality, but it's a very different, the touristic hospitality and the professional hospitality.
Yeah, and let me say, there's again something completely different if you have in a population of million, a couple of thousand, even 10 or 100,000, or if you have an island which is completely overrun, where people living there have existential pressure because of the refugee streams coming in, which I completely understand. So I would completely differentiate the fears, the anxiety, and the panic situation people on the islands have from what we have in a large space in Western Europe, for instance.
Exactly. I have to add also that in Lesbos, which is a very beautiful island, since 2015, there's no tourism.
Yeah.
No tourism at all.
Yeah. that will definitely play into the entire situation with let's call it frustration, or complications from the people living there. I would say that we move on to some of the panel questions we have prepared. Everybody else can continue to type in the questions if you want to into the Q&A box. The first question that we have is, the past year has highlighted pre-existing healthcare inequalities. What can we do to strive for equality in healthcare? And more specifically, and I think this also plays a little bit into the refugee crisis, can there even be a line drawn between our own societies or countries and the rest of Europe or the world? And if so, how can we draw that line? Because we're in a global situation. We have spoken already about the fact that it's a virus, which is, well, it's a pandemic. It's not an endemic. It's not an epidemic. It's a pandemic. And how can there be a line drawn, especially looking, for example, at vaccinations or general health inequalities?
May I answer?
Go ahead. Yeah.
Yeah, I think there are a few things which are very positive, and I think the COVAX facility and the program that WHO, Gavi, others have started in order to provide vaccines to the poor countries at a very high level, which is finally picking up, is certainly a very good point. I also do understand that politicians are, of course, first looking at their own constituency. We as professionals have to remind them that a pandemic is a pandemic, and it means it's not only here, and it cannot be only fought here and locally, it has to be fought globally. Even if we are successful in containing the current wave here, if we don't fix the problem globally, what we will get is we will get more variants or mutations, which again will then threaten us. So that's something that is already going on and what we see. So we have to educate politicians that kind of a vaccination egoism or nationalism doesn't really help us. So we have to broaden this as good as we can. We have started, but yet we are not good enough for that, and it has to be worked on. The second problem lies with the social determinants of health. And that is something that still has to be addressed with or without a pandemic, because we have these inequalities because of the social inequalities which we have in the world. And what we have to do is we have to come to a much fairer economical sharing in our world as we have done it right now. The current trade agreements which we have, even the ones which we have in the drawer, like TPP, TTI, what is it? The European one, I forgot the name already, which is still in the drawer, is up here. Those are exactly the wrong ways in how to deal with a more fairer world. And that is what we have to look for in order really to give a better share for the others to participate in an economic growth and stability, because that will help them as well to deal with their questions in healthcare. Thank you.
Marilie, do you want to add on to that, or?
I think Otmar said everything. I have nothing to add.
Yeah, that was a very good summary. The next question we have, I think Marilie already answered the question where we wanted to ask about if vaccinations have begun. And the other question part, I think you already answered a little bit as well, but maybe just to bring it to the point again, what strategies are being implemented in order to protect the camps like Moria from becoming a new COVID hotspot, when the simple healthcare is not even guaranteed to an extent which we would want them to be guaranteed to, or which we, ethically speaking, should be guaranteed?
Well, unfortunately, I told you yesterday that one of the questions have a very simple answer. No, there is nothing we can do if we have overcrowded camps. There is nothing that we can do. There are a lot of NGOs, especially the United Nations, give a lot of help in the Greek government, and the great support in order to have clean water, in order to have the sanitary things that those people, the population needs. But when we have so many people who live under tents, and the weather conditions are not good, and all this, we cannot do anything. We cannot do. Doctors are there. The hospitals are full of refugees who are in need of the hospital services. But but they're overcrowded. The photos that I showed to you is nothing. If you visit, I visited these places. If you visit these places, it's a shame for the humanity. But they have to move refugees because we cannot afford this this large number in small places. We cannot do that. So this is the answer. We cannot do anything else, nothing more.
Yeah, I mean, the next question that we have, I think, will tie into that again. We wanted to ask, how can we even get involved? Because I mean, you were saying that with the large number of people, there's nothing really we can do to improve the situation, generally speaking. But concretely, also asking from the medical student standpoint, or also just from an individual person standpoint, how can an individual person help or get involved? And particularly seen as there seems to be a lack in EU action regarding the inhumane conditions and the infringements of the Children's Rights Declaration. Now, I had a conversation yesterday with a part of the UN who focused specifically on the refugee crisis in Europe, or generally geographically displaced people in Europe. And they did say that there is actually something going on in the background. However, in the media, we don't see that anything is happening, and it seems to be at a standstill for a while, for years. How can we help? How can we work against or towards more humane conditions?
We have a lot of volunteers, and all those years, a lot of volunteers came and helped. And there were volunteers, lawyers, because we needed also lawyers, we needed civil services, medical students, nurses, midwives. A lot of people came in order to help. Any help is most welcome, of course. But I think that all those things, all those incidents that happen in these hotspots in the camps, come in the media, in the social media. They take advantage, a political advantage of the crimes with quotations or without quotation marks that are happening in the camps. And now that we have the pandemic, nothing else is popular, and nothing else is popular. Was most popular than the pandemic. How many are intubated, how many the new cases we have, what happens in the hospitals, and all this. And in the camps, now it's something that I don't know if it's a vulgar expression, but nowadays refugees do not sell. The news concerning the refugees are not popular, do not sell anymore. So this is a problem. This is a problem. We had a lot of cases of criminalization of solidarity again towards refugees. And we had the document, maybe Otmar knows this document that we had in the CPME on criminalization. And nothing happened. Nothing happened. It's a disappointment, unfortunately. Maybe medical students could come there, and in a volunteer level, they can support for the bureaucracy, the papers, or whatever. And of course, they can make known to the world what happened in the camps. This is the only help that I can imagine. Now there is nothing else. But now that we have the pandemic, it's dangerous also for the medical students.
Yeah.
Yeah. May I come in, Alison?
Yeah, go ahead. Yeah.
So what can we do who are not that much directly affected by the situation in Greece? I think for us, and I'm now speaking as civilians, I think we as European civilians, and I'm now speaking as a European, quite obviously, we have to accept that this is our problem. It's not a Greek problem. It's our problem. And we all have to contribute in our countries to the solution of that problem. And there are different solutions. One is, of course, that these camps have to be emptied And it means that people who have a right to be in asylum come to our countries and are distributed. Some may stay in Greece, but most others have to go to other countries. I know that there are problems with the acceptance of the refugees, but nevertheless, I think we cannot just say, well, we are not going to do anything because some are producing problems or some of the countries are reluctant to help. And this is one of the litmus tests to the European Union. Are we going to solve our problems, or are we only good to sail in sunshine? You know, if the European Union is only good to distribute money to some, then this is not enough, clearly. So we have to also to be able to cope with those problems, and this is one of the litmus tests which the European Union has. And time is running to solve this problem. Now, what can we do as civilians? I think we have to remind our politicians of that obligations, and we also have to be prepared to take on that. Sometimes that takes a little bit of effort by each of us, because it will cost money. It will cost also the willingness to accept other people in our communities. That is something which we have to deal with, but I think that can be done. And I remember when this started in 2015, there was a session which I was a guest at the German Medical Association, and some of the members there were asking, can we do this? Do we have enough resources? And the chair, which was Monty at that time, he said, look at this room. It would mean we put in 2 more chairs in a room which has already 60 chairs. It really doesn't matter. We can do this. And really that is what is true, and we all have to keep that in mind to be open and to work on that. What can we do as physicians? I think as physicians we should never ever accept to treat refugees, whether they are in a camp or whether they are in our communities, different than our own people. So we have to have the same type of care that we would provide. And I would also recommend that when it comes to vaccination strategies, that we include all the refugees which we have there, because if we don't do so, we have a huge and a dangerous problem that we create by leaving them out. So I would strongly recommend to include them, which of course has to be again on the cost of the European Union on the islands. So that cannot be charged only to when it's in Greece to Greece, or in Italy to Italy, or in Spain to Spain. It has to be charged to the European Union, and the European Union has to care for that in order to be done. But we must, as physicians, be very clear that the best way to deal with this is really to integrate and to treat the refugees in the same way as to treat our people. Anything else will produce health problems, public health problems and individual health problems. And only that is a fair way to go. Thank you.
Otmar, thank you very much. It's very moving, whatever you said. And I think that this is the solution. Every one of us can make something, every one of us. But the thing is, if we want to do that, and if we have the willing to do that, and of course, we can force the politicians to see in a different way the refugee crisis. And of course, we have to do something. And since you are in the WMA, maybe you can help for the integration, first of all, the integration of medical refugees who are doctors in their countries. It's a very huge help, because in the camps we have just a small example. I will say we have problems because they have different religions, different customs, and a female doctor cannot examine a male patient and vice versa. So we have to confront these problems. And if we had the medical doctors who are refugees and who speak the language, who know the customs, who know the religions and all this, we could have a better solution in the medical problems refugees have. It's one step. First step is this. We couldn't find this common language. I don't know if WMA can make something in order to legitimize the documentation of those refugee doctors. It's a first step. Then it's the education. I mean, those people need to be educated, need to learn the language, and this is the way that we exclude the ghettos. If we integrate them in the societies, there are no ghettos. It's very difficult to have ghettos. So these are steps that we can do, I think.
Yes. And we have been, for instance, pointing to models of those integrations which have been done. Interestingly, one which was the first one I'm aware of where this has been happened was in the refugee crisis of refugees coming from the Balkans to Hungary, where Hungary has dealt very creatively with that and has integrated those health professionals and has let them work with the refugees in the first place and then to be integrated in the society. Another country which is doing quite well is Lebanon, by the way. Lebanon has a huge load of refugees. Comparatively to Turkey, it's even higher. And they also had a very good integration strategy also to bring in the physicians which have been migrating from Syria into Lebanon, for instance, in order to treat their own patients. And I think that is a way of dealing with problems. Nevertheless, it needs structure, it needs our attention, but it's also part of what our organizations, our medical associations, some of which are in charge of, for instance, issuing licenses or at least supervising physicians, can do and can directly be involved in. And that is what we're advocating for, to take an active point on that and not to be passive and just wait that the system collapses.
Thank you. I totally agree. Thank you.
I think I would just have one last question. You already touched on that a little bit, but the last question I would ask you is similar to the ones I've been asking the other panelists as well. So along the lines of what would your message to the medical students watching right now be, but more specifically also, what can we as medical students do to work more towards equality generally, as well as in COVID times?
Be a good example. I think that is something that we as physicians should really look into be really acting on basis of equality. And equality is a little bit more than equality. I think we all understand. This is something where our healthcare systems are still weak in really to seek where people are in need and to help them proactively. That has been changing over the last 2 decades, I think, considerably already, but we are not yet there. I think we still have to work on that. But then we also have to work politically towards changing problems in our society, because a lot of these social determinants of health are not in our hands directly to change them. Education is one of the fair education, and education for all is one of the most important points to get to a healthier society. I think that's something which we have to keep in mind. And that is something which we also have to tell our politicians. And again, we are not pretty close to anything that can be called ideal with that, because a lot of the inequalities start in the very early youth when the young people, very young people, don't get the necessary support in order to be able to learn properly and to study. And those are the points where we really as physicians have to voice up and have to speak more. And that of course is a role for our organizations as well, or especially for our organizations. And that's true for the physician organization as it has been true for the student organizations as well. Doesn't mean what doesn't happen is our fault, but we are all responsible for that something has happened, and that is a responsibility we should live up to.
I think that the medical students must be better than us, and they must know that when they have chosen to be doctors, they are dedicated. They must never forget what the Hippocrates Oath says: give, and never expect to take something back. Just give. It's not an optimistic, it's not a romantic point of view, but this is what doctors must be. New generations must be better than the older.
Yes, that is a very positive outlook, and I hope that everybody takes that to heart. Thank you both so much for your presentations and for answering our questions and for sticking around, even though we're majorly over the time limit that we set ourselves. I hope that, I'm sure that well, for me as well, it was very, very interesting to see everything and to discuss these things with you, because ethics is something that I feel like is not being implemented in medical education as much as it should be. It depends very much on the universities, in my opinion. Thank you so much for taking the time to speak to us. And please feel free to stick around, and we will move on to our last panel of the day. And
Thank you very much.
Thank you.
Thank you for inviting us.
Then Manuela, are you there? I hope it works.
Yes, Alexandra, can you hear me?
Yes, we can. Perfect. Feel free to turn on your camera.
Yes.
And you should also be able to share your screen. I will just quickly go and introduce yourself really quickly. So we are majorly over time, as I said. I'm really sorry. I didn't want to interrupt the discussions beforehand, because I feel like the topics we're discussing are very important. So our last presentation of today, our last discussion, I put panel in quotation marks because it's one person speaking, is Dr. Manuela Mura, who's a scientific officer in the Office of Biological Health Threats and Vaccine Strategy at the European Medicines Agency. Manuela is a trained doctor in veterinary medicine and has obtained a PhD with a research project focused on indigenous sheep retroviruses, which was conducted in the USA. She worked for further 6 years in basic science at the University of Glasgow in the UK and at Imperial College in London, focusing on retroviruses and influenza viruses, respectively. From 2010 until 2019, she was the scientific officer at the European Medicines Agency in the Office of Anti-Infectives and Vaccines, with a main focus on vaccines. Since 2020, she's a scientific officer at EMA in the Office of Biological Health Threats and Vaccine Strategy, with a focus on COVID-19 vaccines and the ongoing pandemic. And she will tell us a little bit about the process of approving a vaccination or a vaccine in Europe. So it's called the rolling review process. And I hope that that I'm sure that we will learn a lot about the process, because this has led to a lot of question marks, let's say, in the public. So Manuela, please go ahead.
Thank you very much, Alexandra, for the introduction, and thank you very much for the invitation. I think this is a great forum to give you a little bit of information of how EMA authorizes vaccines, and overview, especially on the COVID-19 vaccines that have been authorized in Europe. You can see the slides well, right?
Yes.
You can hear me? Okay, perfect. So I will not spend any longer on this, but just on the outline of my talk today, I will give you an overview of the main milestone which have supported our authorization, a little bit of data and discussion around how we concluded on the benefit and risk of COVID-19 vaccines, the importance of real-world evidence on effectiveness, what is the situation with the pediatric development, and which vaccines are currently under review by EMA, and the issue with variants which are now emerging, and what are the concerns of the regulator and what actions are taken, and then my conclusions. So this slide is to show you the milestones in the fight against the pandemic from our perspective. And just to tell you that pretty much like everybody else, we have mobilized several scientific and regulatory resources since December 2019 and January 2020, so very, very early on. And from roughly February or March, after WHO declared the pandemic, the key group of experts at the level of the EMA was activated, which is the COVID-ETF Pandemic Task Force. ETF stands for EMA Pandemic Task Force, indeed. And we have an health threat plan which kicks in normally as soon as an outbreak starts. So we are very well prepared following the 2009 influenza pandemics and all the other outbreaks of Ebola and Zika in the past years. And therefore, this group of COVID ETF is very key in driving the discussion with the companies, with the vaccine developers, and in assessing then the data whenever they are available. So rapid development was put in place by the company, but we supported their development with rapid scientific advice during the stages of development, and then rapid evaluation of the data, as you said, via the rolling review as one of the tools that we have available at the level of the EMA. And in addition, especially during approval and after approval, transparency, it's important, and we have increased transparency a lot to make sure that the public understands how vaccines are approved, under which basis, and what data are supporting our decision. And then outreach is key in terms of discussing with international regulators to ensure that we have an harmonized approach globally to facilitate development and concerted regulatory actions as much as possible, but also outreach to stakeholders. And importantly, these are patients, but also key healthcare professionals such as yourself pretty soon. So all these activities have allowed EMA in less than a year to be able to authorize 4 vaccines against COVID-19 already. And this is just to show you indicatively what are the timelines for the vaccine development and assessment. On the left-hand side in blue, you see what happens with standard vaccines, where we have the regular clinical development program preceded by investigational discovery of the product, non-clinical research, and then the clinical development, which is split by phase 1, phase 2, and phase 3 clinical trials. But only after all of this is done can a regulatory authority start an authorization, the assessment of the data and the authorization. And after that, the product is authorized, companies scale up production, and at that stage, vaccines are available for use. All this process takes up to 10-15 years, and the authorization step can take normally 1 or even up to 2 years. What happened during COVID, which you can see on the right-hand side, the purple graph, is that first of all the development has been compressed in time. So there has been no cutting corners, but a lot of, as I said before, scientific mobilization, but also more funding by government, by company, more people, more resources, all dedicated to COVID, and a lot of creativity to, for example, adapt a phase 3 study design so that they could start as a phase 1 and then move to phase 2 and phase 3 based on a minimum level of data in terms of immunogenicity and safety that would allow to take the decisions to move forward to a larger sample size. And what is key, in addition, also companies have started scale up production at risk before a regulatory decision has been made, which can, of course, facilitate deployment of the vaccine after authorization. But what is key here is that, from our perspective, is that the regulatory assessment of the data could start, as you can see, already during the clinical development. As soon as we have phase 1 proof of concept data in terms of immunogenicity and safety, EMA started assessment via rolling review, which is a procedure, very agile and flexible procedure, whereby we allow companies to submit the data to the EMA in discrete packages, as depending on what they have ready and available. So normally we can start with non-clinical data and manufacturing data, which are the first ones that are prepared, and the clinical data are then coming afterwards as they become available. And like this, the assessment can start very early, and by the time we have confirmatory data, efficacy and safety from the pivotal phase 3, large phase 3 trial, we are at the stage where most of the dossier is completely assessed, and we can make a regulatory decision on the benefit risk assessment very rapidly once the pivotal data are available. And so far, we have 4 vaccines authorized in Europe. based on this system. The 4 vaccines are based on 2 different platforms. Comirnaty, which is the BioNTech Pfizer vaccine, and Moderna, developed by Moderna. They are the so-called messenger RNA vaccines. Basically, they contain a molecule of messenger RNA, which is embedded in lipid nanoparticles. The lipid nanoparticles facilitate uptake of the cells and of the messenger RNA, and also they avoid degradation of the messenger RNA, which would otherwise be very labile in the environment. And the messenger RNA only contains the instruction for the cells to translate and produce the spike protein of the SARS-CoV-2 virus. Instead, AstraZeneca and Janssen, they are based on adenovirus vector. And these are harmless viruses, some of which are also infecting humans or other animals, which have been manipulated to be deficient, so they cannot replicate. They're only able to enter the cells and deliver their genomic content, which is a piece of DNA carrying the genetic information to be able to produce the spike protein, also in this case of SARS-CoV-2. Therefore, these vaccines do not contain any virus and are able, therefore, not to cause any disease, any COVID-19 disease themselves. And you can see here the timelines of approval, with Comirnaty being approved just before Christmas, followed by Moderna early January, AstraZeneca end of January, and the Janssen vaccine is the last vaccine that was approved in March. Which are the data that supported EMA and the scientific committees in the decision to support a positive benefit-risk balance? Because all vaccines, in order to be approved and used, have to have a positive balance between the benefits and the risk in prevention of COVID-19 disease. Messenger RNA vaccines have shown a very high efficacy in large trials in preventing symptomatic COVID-19 of any severity. And similarly, also viral vector vaccines have demonstrated protection against symptomatic COVID. Now, because the vaccines have been studied in different trials, it is not possible to make a direct comparison of the efficacy rates reported, because trials are done slightly different by each company. They may have different endpoints, different methodology, different testing, but also different populations and different geographical situations where they have been conducted. Therefore, to make a direct comparison between the 95% efficacy of Comirnaty against the 65% efficacy of AstraZeneca is not really what should be done from a scientific perspective. So the important point here is that all vaccines are very effective in preventing symptomatic COVID-19, but also they are able to prevent severe disease, hospitalization and death, which has been shown in clinical trials. The data are relatively more limited compared to the overall burden of disease of symptomatic COVID. But trends are clear for a high level of protection against these very important endpoints, especially from a public health perspective. Currently, another important point is efficacy against variants. I mean, what's going on here? And we have at this stage limited information from clinical trial, but I will tell you a little bit more later. Another point that is important to note is that the benefit risk of the vaccine is not crystallized at the time of the authorization, but continues afterwards, based on the data coming up from the safety monitoring, from real life use, but also based on the real world data, which is the effectiveness data that is generated in observational studies. And this data is extremely important, for example, with respect to prevention of infection. Because that is something that is able then to understand how much vaccines are able to spread, to limit the spread of the virus, transmission of the virus. Now, data in this regard have been reported. More are needed for proper estimation, but I will tell you also a little bit more later on. Regarding safety, all vaccines have shown a good safety profile, very much in line with any other vaccines that has been approved so far. Most common side effects are usually mild or moderate in intensity, and they are temporary. They last normally a few days. And these very common side effects include local reaction at the injection site, such as pain and tenderness, and more systemic reaction, such as headache, fatigue, malaise, or myalgia, arthralgia, chills, fever, and nausea. Very rare but severe allergic reactions, such as anaphylactic reaction, have occurred in people receiving the vaccines, which is not unexpected. It could occur with vaccines and other medicines for that matter. But this is, let's say, not really of concern, because these type of reactions are known how to be handled, and therefore, as stated in section 4.4 of the SMPC, vaccinees should stay at the clinic where they receive the vaccine for at least 15 minutes in order to be treated should such event occur. And then very rare events of severe thrombosis combined with thrombocytopenia have been observed after AstraZeneca vaccination. Very, very rare, because they seem to be happening in around 1 person in a million. Although this magnitude is subject to further investigation. And the PRAC, which is the Pharmacovigilance Committee at TMA, have concluded recently that a causal relationship between the AstraZeneca vaccination and these very rare events of thrombosis and thrombocytopenia could be there could be a plausible causal relationship, but now there are further investigations to understand more about the mechanism of action, what is actually happening, what are the risk factors, what can be done to minimize this risk that is already very, very rare, but what can be done to minimize it as much as possible. And also, final point, long-term safety is being monitored. This data will be coming from the ongoing phase 3 clinical trials, which are still ongoing. As you know, these vaccines were approved under conditional marketing authorization, which means that only based on less comprehensive data compared to NORMA this is another tool in addition to the rolling review that allows regulators during emergency to be able to approve vaccines and other medicines in a rapid manner. But there are conditions imposed to the companies, and they are legally obliged to produce the data that are requested by regulators, among which long-term safety, but also long-term immunogenicity, which are the data that are coming up from the ongoing trial. And in addition, other studies have been imposed to, as reflected in the risk management plan. And I forgot to mention that here you also have the links to our website where all the full scientific assessment and the product information is published. I just included a couple of slides on the safety monitoring and when this is done throughout development. You can see in light blue the phases of development, again at the bottom, pharmaceutical quality, the manufacturing development, the non-clinical phase, the clinical trial, and safety monitoring occurs throughout in terms of investigation, looking, impurity during manufacturing of the vaccine or other aspects, but also toxicity during non-clinical. And then side effects are reported during clinical trial and collected via EudraVigilance, which is the European database of suspected adverse reactions to medicine. EudraVigilance will collect side effects, potential side effects, also after authorization during the post-marketing safety monitoring, as you see in pink at the right side of the slide. And post-marketing safety monitoring is then made up of reports from patients and healthcare professionals of potential side effects following vaccination, but also reports will come from safety studies that are conducted by the companies or other authorities post-authorization, from medical literature, which is regularly assessed, and finally information from other regulators worldwide. So all this is constantly assessed by the pharmacovigilance risk assessment at the level of the EMA to fine-tune over time the safety profile of the vaccines. And this is just, I wanted to include here the link to the UDRA vigilance. And just to say that based on reports from patient and healthcare professional, there have been up to 22 March around 200,000 cases of suspected side effects received in this database based on Comirnaty, Moderna and AstraZeneca, monitoring of safety post-authorization, but this means that they are only suspected. And then a lot of work is put into understanding whether there is any difference between the side effects and whatever has been seen in clinical trial, whether the product information needs to be updated, patients informed, and whether a causality is also plausible. And this one, just to tell you that who has reported in UDRA vigilance seem to be half and half between healthcare professionals and also non-healthcare professionals, because even patients can report themselves and what they suspect could be a side effect to regulatory authorities, but also directly to companies or directly to their healthcare professional. Now, another part of post-authorization monitoring is not only safety, but also, as I mentioned earlier, real-world effectiveness data. This data is very important because complements what we have seen in the larger clinical trial efficacy that have been assessed pre-authorization. And we have a lot of plans to use this type of data from the clinical practice in order to monitor safety and effectiveness of the vaccines over time. And you have here a link to see specifically all our activities, especially in collaboration with the European CDC, with the support of the European Commission. And this type of data is very important because it can inform vaccination campaign and change in current practice of vaccination. For example, they can provide information on how long protection lasts for and how well the vaccine is able to prevent severe COVID, for example, which are endpoints that are more difficult to fine-tune to have a precise estimate during clinical trial, because we would require longer time for follow-up and a larger data set, which is not very practical in terms of timely decision. But also this data will tell us how the vaccines are able to protect immunocompromised people or other vulnerable population, which are more difficult to study in clinical trials when we know still relatively little about how safe and effective the vaccine is to expose these vulnerable populations. And finally, it will tell us an important piece of information, which also cannot really come from clinical trial, which is the prevention of asymptomatic cases, and therefore how much vaccines are able to block transmission within the community. So far, at least 4 effectiveness studies have been published, and mostly they are from Israel and the UK, which are countries that have are very fast, have been very fast in deploying vaccination. So the data are actually quite robust. Although there is still a preliminary assessment performed by the EMA COVID task force, the data are promising. For Comirnaty, for example, prevention of infection in Israel have been shown up to 92% of effectiveness after 2 doses, which is very good. And for AstraZeneca and Comirnaty, both of them, there has been data showing substantial reduction in the risk of hospitalization in the UK, up to 80%. But as I said, these data are very encouraging, but are also preliminary, and more data are awaited. But the important point is that they are confirming so far what we have seen in the clinical trials. For Comirnaty, they are confirming that the second dose is important, and it's boosting the immunity induced by the first dose. And for AstraZeneca, for example, an important piece of information is that the data, the effectiveness data, is shown high protection from COVID-19, including severe disease, already after the first dose, and also high efficacy in the elderly, which, as you know, was a population that in clinical trial had more limited data. So it was very difficult to conclude on a precise estimate of efficacy. Regarding children, the situation is still under development. Only one vaccine is partially approved in the pediatric population, which is Comirnaty, which can be used above 16 years of age. Moderna, AstraZeneca, and Janssen can only be given above 18 years of age at this stage. But the vaccines are all under development also in the pediatric population. They will first be tested in adolescents, and then there will be a staggered approach as soon as immunogenicity and safety is observed to then go down in age to younger children. It is not known exactly at the moment when this data will be submitted because the studies are still ongoing, but we know that the messenger RNA vaccines are recruiting very fast. So this data should become available fairly soon. And here a couple of slides to tell you that we have 3 more vaccines under assessment via the rolling review procedure, and just a little bit of information about them. The first is the vaccine from Novavax. Here in brackets is the company code for it. The rolling review started at the beginning of February. This vaccine is a more traditional type of construct, is a protein-based vaccine. It contains the actual protein, recombinant protein of the surface spike protein of SARS-CoV-2. And it also contains an adjuvant, which is a relatively novel adjuvant, the matrix adjuvant, so-called based on saponin. And the role, of course, is to strengthen the immune response to the vaccine. We also, for Novavax, we also have available efficacy data. It's in the press, showing a very good level of efficacy, but the rolling review is still ongoing at this stage. And another one is the vaccine from CureVac. CureVac started rolling review in February, and this is another messenger RNA embedded in lipid nanoparticle, pretty much like Comirnaty and Moderna, and large clinical trials are ongoing at this stage. So we have limited information, but the rolling review is ongoing on manufacturing and non-clinical data. And finally, Sputnik vaccine, which you've been discussing earlier. This one was the latest start in early March for the rolling review. Sputnik has, it's similar to AstraZeneca and Janssen because it's based on the adenovirus vector. But differently to those, they have applied another strategy, which is called heterologous booster. So basically, the vaccine is made of 2 parts, based on 2 different adenovirus, the adenovirus 26 and the adenovirus 5. And they are given as 2 different doses. So one is able to prime the immune system and the second is able to boost. And this heterologous boosting is important because it's been shown with other products to be able to improve immunity against the vaccine based versus homologous booster. This vaccine are only expressing the spike protein of the virus. They cannot cause any disease. And the rolling review is ongoing, and we have also inspections planned for the clinical trial sites, which are actually ongoing as we speak. Another important part of the approval of vaccines is the aspect of the variants, because the virus is an RNA virus and it mutates very frequently. This is not unexpected. So variants emerge all the time. So what is important, and this is something that WHO is coordinating and working very hard on, is to ensure that there is adequate surveillance globally to spot this new variant and to be able to map them and to be able to characterize them to identify which variants are of concern, which means which variants are mutating so much to alter the antigenic profile so that the vaccine are not able to respond to them anymore, not able to build immunity and to protect against COVID. And there may also be able to improve, increase transmissibility or to increase severity of disease. These are the worst variants, and there is a lot of work trying to make sure that these are identified as soon as possible, that data are generated as soon as possible to understand how vaccines are responding to them, and then to decide when is the right moment to switch the composition of the current vaccine to include the new strains, the new spike proteins. This requires continuous monitoring of the vaccine performance over time. So this is again point to the importance of real world data, effectiveness data coming from observational studies. And discussions are ongoing regularly with all companies from our side, from the regulator and the experts, to understand what they are doing, which type of development they are planning, which type of data, and also to discuss what scientific requirements are necessary for approval of these new variants. And because this would be variations of existing vaccines, and we have already a lot of evidence, it is an update of the composition can be done reasonably quickly. There is no need in principle for large-scale trials, and also no need for efficacy data, but the variant vaccine will be compared with the parent authorized vaccine in terms of immune responses. And because the parent vaccine will have proven efficacy, we can infer efficacy of the variant based on a similar level of immunogenicity. And all of this we can do reasonably quickly because we are basing on the existing knowledge and expertise with the seasonal influenza vaccine. As you know, also that is a virus that mutates every year almost for all the strains. And this is now it's a very established process, and a building platform to consider for COVID-19 vaccines as well. We have a guidance for vaccine developers that is establishing all the endpoints and the regulatory requirement necessary for this vaccine to be able to include a new variant. And essentially, just to give you a flavor of what is going on, we have three main variants at the moment circulating, and based on clinical trial, but also some effectiveness data, the vaccines currently authorized in Europe are expected to provide protection against the so-called UK variant or Kent variant, which is the B117. Some vaccine, it depends on the vaccine, but some may also be able to protect against the South African variant, the B1351, at least in terms of mild disease. There is some data available, but more studies are needed to understand the level of protection against severe diseases, hospitalization, although it's actually expected based on what we are seeing. For the Brazilian variant, the P1, this is for this one, we have really no data available, but some is coming up. And of course, I mean, despite the large studies and the extensive data set that have supported the authorization of this vaccine, there are questions which are pending, and questions that are also coming up from the data that are being generated post-authorization, and from questions from real use of the vaccine and from public health authorities. For example, the need for 2 doses for individuals who had a history of COVID-19 is being questioned. It could be that there is some evidence showing that only 1 dose may be sufficient, but at the moment we don't have the sufficient amount of data to be able to make a robust decision and a definitive decision on this. The interval between doses is also been discussed essentially because of the limited availability of some vaccine issue with supply in some member states, and therefore public health authorities are thinking whether it's possible to give the second dose a little bit later so that vaccine can arrive. And while there is more flexibility perhaps with vaccines such as AstraZeneca, because trials have looked at different intervals between the first and the second dose, for the messenger RNA, this is a little bit more difficult because the studies were really precise in looking at 3 or 4 weeks between the 2 doses. So the risk, if we extend, the risk is that we really don't know how long a subject will be protected after 1 dose. And there is the risk to expose them to COVID, obviously, before the second dose is administered to ensure a full protection. The other important point is the possibility to boost with different vaccine. So if we have given 1 dose of vaccine, can we use another type of vaccine for the second dose? This is something that we cannot answer at the moment, but a lot of trials are starting to look into the so-called mix and match approach. And this is an important point for public health authorities as well. And finally, we don't know much about the use in immunocompromised and other special population, because as I said, these populations are very difficult to study pre-authorization, and more data will be generated by manufacturing and public health authorities in the coming month. So just to briefly summarize how vaccines can help to beat the pandemic, they provide an immediate benefit to people who will be protected against COVID-19 symptoms. But also, if fewer people are getting sick, this means that the burden of COVID-19 disease is less, and healthcare system don't struggle as much. So there is an important public health benefit in addition to the personal benefit. And another important point that vaccine can with which vaccine can help beat the pandemic is that they may be able to reduce virus spread. And this is something that still needs to be confirmed, but preliminary data from the effectiveness data from Israel are showing that whenever they reach high vaccination coverage, infection rates are falling. And this means that potentially we can reduce or stop the spreading of the virus. Of course, vaccines remain essential to beat the pandemic in terms of reducing symptomatic disease, but this doesn't mean that we can immediately return to normal because of all the uncertainties, and because we have to have high vaccination coverage as shown by the data in Israel to be able to see robust effect at the level of the community. And therefore, non-pharmaceutical interventions such as masks, hand hygiene, and social distancing remain essential. And this is just to tell you that EMA is operating on an increased transparency. Therefore, we are publishing many more documents than we used to be, to many more information on how vaccines are developed, evaluated, approved, and monitored, addressed to both a professional audience or a general public, but also addressing all questions from the public. So you will find all this information on our website. This is just a quick overview of our ongoing activities, the number of companies we have been discussing, and other all the guidelines that we have developed. And an important point is that international collaboration with WHO and regulators worldwide has been key during the pandemic to support a faster approval of vaccines. And here is more or less what I have already said. Vaccines offer a very good level of protection against COVID-19 disease. Based on preliminary effectiveness real-world data, they also may be able to reduce transmission, severe disease, and hospitalization, but we need further data to confirm. They have a positive, a beneficial safety profile with most side effects, mild to moderate in severity, and more data will be coming up in the context of the conditional marketing authorization in the post phase. Variants are of concern. There are a lot of discussion around them. Vaccines may need to be updated in the near future, and more data is coming, and vaccination remain critical to control the pandemic. And this was my last slide. I give the floor to you, Alexandra. Thank you for your attention.
Thank you so much for all this insight. This is all information that I think, well, it's not being published in common media. So I think this was very, very interesting to everybody listening in. We have a few questions. I realize that I know that the next event is starting in about 10 minutes, but I think we can go through them. So one of the questions that we wanted to ask you is, how can we tackle vaccine hesitancy towards the rolling review accreditation process, also towards the new mRNA vaccines, and also towards the AstraZeneca vaccine, especially taking into consideration the current media coverage concerning AstraZeneca?
Yeah, well, yes. Now, first of all, I have to say that EMA has no role in promoting vaccination or a specific vaccine, but we have a key role in promoting trust and confidence in the robustness of the regulatory system for approval of vaccines and for their safety monitoring afterwards. And key to promote this trust is the close collaboration with the networks of patients, consumer and health professionals, and especially the latter. Like, this forum is extremely important for us because, you know, we believe that doctors will be the herald of correct scientific information. How to do this, how EMA is trying to tackle hesitancy. There are several ways to do that, but apart from collaboration, is also to improve communication, routine communication on benefit or risk on vaccines, how we make decision, what data is supporting our decision, and when the data changes, we try to communicate as fast as possible. And we try to ensure that also at the level of the European member state, there is a consistent message by all the national regulatory authorities in terms of vaccines benefits and risks. And then more openness and more transparency. We publish more and more documents. We have public stakeholder meetings recorded and open to the public to any questions. And we try to point and encourage the public to trust only reliable sources. For example, the European Vaccination Information Portal, which is done together with the ECDC, the European CDC. But in terms of rolling review and approval of the vaccine, this we need to state very clearly that this is an incredible success story and an historical achievement, because, for example, Comirnaty was authorized in less than 11 weeks, but this is not done simply by shrinking timelines. It is done by carefully planning all the activities, engaging with developers since the summer, starting the rolling review as the main tool to ensure a faster assessment of the data since October, which then allowed to reach a robust decision in less than 11 weeks. And in addition to this, we have to say that the whole network, a lot of people was dedicated and mobilized for COVID only, and everybody has been extremely responsive, especially also the company, obviously, which is an important part of the equation. And in addition, the COVID ETF, as I said even earlier, is a very agile structure that allows very fast decision based on evidence to support the scientific committees in their final decision. So because vaccines are to be given to millions of people during a pandemic for a mass vaccination, we are keenly aware of the huge responsibility that we have to get this recommendation right. And therefore, it is of the utmost importance for us to make sure that we are reaching decision based only on sound evidence, and that this is clearly communicated to the public. Our conclusion is that, for example, for messenger RNA vaccine, the decision was based on large clinical trials up to 40,000 individuals, and that all the vaccines approved are based on rigorous EU standards for safety, efficacy, and quality, with the evidence that is the most convincingly showing that the benefits are greater than the risk for this and all the other vaccines that have been approved. You had perhaps another point?
Yes, we had one more question. Actually, we have one more in the Q&A as well. But first of all, from my perspective, one of the main issues with the AstraZeneca vaccine, as we were saying, is the hesitancy are aforementioned differences in recommendations. How come that the FDA, so the American version of the EMA, so to speak, and EMA have different recommendations?
Well, there are a couple of points here. First of all, this recommendation that you say are different are at the level of the member states, but at the level of the vaccination recommendation, because here there are two aspects. Number one is the approval, and the EMA is responsible for the European level approval, scientific opinion to support approval of the vaccine. This has not changed, because the indication is open in adults for the AstraZeneca vaccine, and that has not changed. What has changed is the vaccination recommendation, and that is under the national responsibility, is in the remit of the member state. and is made by public health authorities or by the Ministry of Health. And they use the regulatory recommendation, but they applied that based on their own characteristic, in the elements of their own territory, which means that they look at availability of the vaccine, alternative type of vaccine, vaccination priority, but also epidemiology, infection rate, hospitalization rate. So all these aspects can vary from one region to another, from one member state to another, and this may lead to different recommendations by different public health authorities in the different member states. So that, I think, is an important aspect to consider. With regards to the US, AstraZeneca still is not approved in the US. They are, I understand, they are about to send a request for an emergency use authorization to the FDA. So FDA will have to start the assessment of the data, I understand, soon, although I don't have any more information than this. But an emergency use authorization also is not an approval, is the possibility to use an investigative product before an authorization is reached in order to get there faster during an emergency. So that's what I understand the FDA will do. So it's a slightly different approach, but at the moment AstraZeneca is not yet authorized in the US, so there is not really a big difference there. But having said that, it may be possible to have a different recommendation by FDA, because we have different legislation and different requirements. So some differences cannot be avoided, but I have to say that we closely collaborate with FDA, not only them, but also Health Canada, MHRA, and other regulators. And also we have a hub for international collaboration, which is ICMRA, an organization which brings together all the regulatory medicines worldwide. And especially with FDA and Health Canada, we have regular discussions. We have a confidentiality agreement, so we are able to share data openly. And this discussion has been obviously increased during the COVID pandemic, but have been there since a number of years now. So we are used to discuss, and the aim is to share information, share data, but also reach an agreement on the main scientific point as much as possible. But then some differences, may remain depending on the different legislative system and of the two regulatory regions. In terms of for AstraZeneca, I mean, of course, I think I understood from your question that the safety issue that has been identified is with different recommendations.
Exactly, yeah.
That can then increase hesitancy.
Exactly.
And how to then deal with that. I think we need to look at the positive aspect here, which is the fact that the pharmacovigilance system has been working very, very well. So based on only a few cases of this very atypical syndrome, the process has been started immediately. And this is only showing how challenging it is to have a mass vaccination in process, because no matter how large the clinical trials have been, and in this case they've been very, very large, larger than any other clinical trials for vaccines before, still very rare events can only be identified when millions of people are vaccinated at the same time. And therefore, it's key to have a strong pharmacovigilance system, and we have one at the level of the European Union, which is able to detect and analyze the risk as soon as they are, and so that then we are able to take action. And I think this is important to remind to people that this is what is happening, and that EMA will look at all the data and will prepare a scientific opinion, and then member states will use the outcome to define their own national vaccination policy based, as I said, on the characteristic in their own territory. But also important, I mean, sharing information is the most important tool against hesitancy. One of the many, but probably one of the most important one. And we need to make sure that also people understand that further research continue to be ongoing. So there is nothing crystallized in time. As the data come in, the assessment continues. Further research have been imposed to the company to clarify this rare event of atypical thrombosis with thrombocytopenia, to understand the mechanism of action in order to minimize the risk as much as possible. And letters have been prepared to be and shared across the member state to be sent to the healthcare professionals so that they can identify the signs of the event as early as possible, and the person can be treated as quick as possible. And the same also for the patient themselves, so that they can identify if they have headache or blurred vision after vaccination, or if they have shortness of breath or chest pain or abdominal pain, they can contact. So all of this is important that for people to know. And these are the only tools that we have to tackle hesitancy and to make sure people understand that things are taken very seriously and that there is a reason behind any decision.
Yeah. The last question I think I would ask you is the one I asked every single panelist. So what would your message to the medical students listening in be, if you wanted to give a very concise message that you want to give to us, so to speak?
I think, if I can take this opportunity, which is very great, is that healthcare profession can only lead by example, and doctors are in a especially important position to do that. So that it's important that they know the facts, the data, the evidence, and how the system works, and that they are able to then tell people and explain to people and clarify that no medicine is 100% safe and effective, but is always a balance of benefits and risk. And this is very difficult to understand clearly, but especially for vaccines, because they are administered to healthy people. So it's important that also the risks are put into context. With respect to other medicines, or with respect to other situations, for example, for thrombotic events, for example. So I think doctors are in a unique position to be able to be to lead by example, for the importance of vaccination and of robust data to inform the public and to ensure that hesitancy is tackled.
Thank you so much for all that information, and thank you so much for the presentation, for taking the time to speak to us today, and also for staying with us even though we're massively over the time limit. But I very much appreciate it. I think that it is all the information provided is, as I said, something we don't usually get easily or get access to easily. Now, I, for my job outside of EMSA, have to keep up with the news of EMA anyhow. So, but this is not something that someone does usually. So thank you so much for taking the time. This brings us also to the end of our symposium. And I want to thank all the panelists for being here today. And I want to thank everybody for listening in and for submitting the questions so frequently. It really was a pleasure from my side, and I really hope that all the attendees enjoyed the discussion and that it was also a little bit of fun for the panelists, even though it was a lot of work. I think we have a lot of things to think about after this, and I think that one question which was submitted, which we didn't answer, was if we think that if it was to the question on ethics, that if hate and prejudice will increase in the future. I personally think that this ties in with the overall message, not only of preparation being needed for future pandemics, but also for the medical students to lead with an example. So I think that we definitely need to take that into account and lead as an example in the future, and in our jobs, in our medical schools, and ask each other how we're doing in terms of mental health as well. So I think there's quite a few take-home messages that we can draw from this incredible group of speakers and all these presentations. Thank you so much. And hopefully everybody will stay on for the trainings that are going to start very soon. And thank you to all the speakers also for staying around until now. Marini, thank you so much. And we will be in touch very soon. I'm going to stop the live streaming now. I hope that everybody's okay with that.
Thank you very much.